I can start. That's 9:30. Welcome to everybody, and can I start by asking everybody to make sure their phones are switched off? Thank you very much. We have apologies this morning from Tavish Scott. That's all. Everyone else is here. Item 1 on our agenda is a decision as to whether we take items 5, 6 and 7 on our agenda in private. So can we agree that we take these items in private at the end of the agenda? Is that agreed? Thank you. Which takes us to our first panel this morning, the Section 23 report, just laid, prescribing in general practice in Scotland. This report from the Auditor General, and we have the Auditor General with us to speak to the report and answer questions, and she is with her Barbara Hurst, Director of the Performance Audit Group, and Tricia Meldrum, also from the Performance Audit Group at Audit Scotland. So I'll just ask the Auditor General if she'd like to introduce the report.
Thank you, Convener. The NHS in Scotland spends about £1 billion a year on prescribing in general practice. That's around 10% of NHS boards' budgets. And last year, GPs issued 91 million prescriptions across the course of the year. What we've tried to do in this report is to assess how well the NHS is managing this spending, following up previous reports that we published in 1999 and 2003. Overall, we found that the NHS has done a good job in improving its management of GP prescribing. Spending fell by 11% in real terms over the past 7 years since 2004, at the same time as the volume of prescriptions has risen by a third. That's a real contrast with what was happening previously. In the 7 years up to 2004, spending increased by 50% in real terms, so a real shift in the direction of travel for spend at a time when the volume of prescriptions is increasing. One of the main reasons for this is the support and guidance that's now being provided to GPs to help them manage their prescribing, both in terms of keeping the costs down and meeting the needs of patients who come to them requiring drug treatment. This support includes support for GPs from prescribing advisors employed by health boards, agreed local joint formularies which give GPs guidance in primary care and also prescribers in hospitals on the sorts of drugs to prescribe, and published best practice clinical guidelines to help them make sure that they are hitting the clinical needs of their patients. Overall, the NHS now has much better quality information on GPs prescribing, and NHS boards and GPs are using that information to help target the areas where they can improve, and we're seeing that in the costs of prescribing as well as the quality achieved. In an area that accounts for more than £1 billion of spending, the NHS needs to continue looking for opportunities for improvements and savings. We have identified scope for further potential savings of around £26 million a year without affecting patient care. This could be achieved through two main measures. First of all, reducing unnecessary waste, such as patients getting repeat prescriptions for drugs they're no longer taking. And secondly, reducing the use of drugs that are considered less suitable for prescribing, for example, because better or more cost-effective drugs are available. We looked at the impact of the abolition of prescription charges from 2011 to see whether that had had an impact on prescribing. Overall, we think it's too early to tell whether there is an impact, but we certainly haven't found any evidence so far of a significant change, and we'll continue to keep this area under review. We have recommended also that the Scottish Government should monitor the impact on an annual basis. Looking ahead at this important area of NHS spending, we know that demographic factors such as the age of patients and deprivation are associated with higher levels of GP prescribing. Lifestyle factors such as obesity, smoking and alcohol misuse and associated illnesses also have an effect. This means that levels of prescribing are likely to continue to increase in the future, but some of the effect on spending will be offset by other factors, particularly falls in the price of some drugs as they come off patent. We estimate there'll be annual savings of about £86 million in general practice from drugs that come off patent in 2012-13. Finally, we looked at the quality and safety of prescribing from the patient's point of view, and particularly the challenges of patients who are taking a number of different drugs. those people do have a higher risk of either side effects or interactions between the drugs that they're taking. And we found that over 900,000 people in Scotland are taking 4 or more different drugs at any one time. In October 2012, the Scottish Government issued guidance on reviewing and improving prescribing for patients taking multiple drugs, and we've recommended that NHS boards should work with GPs to implement those guidelines and make sure that those patients are being treated as safely as possible. Convener, I'll stop there, but we're happy to answer the committee's questions.
Thank you. Thanks very much. And I kind of feel, because we are the Audit Committee, should start by acknowledging what a good news story this report would appear to be between 2004-05 and 2011-12. Excuse me, an increase in the quantity of drugs prescribed by 33%, but a drop in spending by 11% in real terms. So surely the kind of information that should gladden the heart of any Public Audit Committee, and that is, I think, a remarkable story. I just wanted to tease out why that's happened. One of the reasons clearly from the report that that's happened is an increase in the prescribing of drugs which have come off patent, and the report points to as much as a drop of 94% in cost when a drug is replaced by a proprietary drug's replaced by a generic equivalent. So I suppose the question I want to ask is this. Presumably drugs come off patent all the time and new drugs are developed and come onto the market. So is what we're seeing here, for some reason, a lot of drugs coming off patent and becoming cheaper, or are we seeing a real change in the prescribing behaviour and the way the NHS prescribes drugs?
I think it's the latter. We're seeing a real improvement in prescribing behaviour. You're right, one of the things which has made a difference is the number of drugs that are available as generic drugs rather than patented drugs, but that's always been the case. When we looked at GP prescribing back in 1999 and 2003, we found a much higher proportion of drugs being prescribed as branded drugs rather than generics. The thing that's made a real difference is NHS boards working with GPs, GP practices, to give them that support to target where they can improve their prescribing and to really change that behaviour. I'll ask Tricia to give you a couple more examples where that may have been the case.
So we found NHS boards were employing teams of staff who could work with GP practices to really target areas for improvement. So that could be things like data analysts. There's very good quality data available now on GP prescribing. So data analysts could be analysing that data, looking at areas that they could target within a particular board or within a particular practice or CHP level for improvement. Then also in prescribing advisors, who may be people like pharmacists who've got specialist knowledge of drugs and specialist knowledge of best clinical practice and clinical guidelines, who again can be working with GP practices to raise awareness of that best practice. And we also found examples of board-employed pharmacists working with GP practices, so being based for some sessions a week in GP practices and working with either the GPs or working directly with patients to do things like medication reviews. So really helping the GP practices to target areas where they could improve their prescribing, and we're seeing things like that making a big difference. Also having joint local formularies, which would be the agreed drugs that would be recommended for use locally. These are now agreed between general practice and hospitals, so you're seeing that continuity of care as well, which again is making a difference.
Okay, thanks very much. Ms Scanlon.
This wasn't my prepared question, but it was just when you were talking about the data analysts, obviously that's very welcome, but it did sort of take me back to Exhibit 5. There's quite a difference, just at a rough glance, about 30% more prescribing on spending on GP prescribing by, let's say, 5 than Greater Glasgow. So, given that the best practice clinical guidelines, the data analysis and all the advice and initiatives on prescribing, why are we seeing such a variation there?
Again, I think we've made recommendations about some areas where boards can continue to target that further. We've also made recommendations that boards where they perhaps have less of the prescribing support staff in place, where they do have higher prescribing quantities or higher prescribing costs, that they perhaps might want to look at whether or not there is scope on a spend to save initiative to look at improving or increasing the prescribing support that's available to their GP practices.
It did seem to be quite a variation. Convener, my questions are actually sort of about page 16, 17 and 20. I was surprised in the recommendations on 20 to read, the Scottish Government should remove the incentive for pharmacists to overorder repeat drugs as part of the changes to the community pharmacy contract. I mean, it does seem incredible that there is an inbuilt, an almost incentive to overorder drugs, you know, when we're saying to patients don't stockpile and don't waste, etc. And if I could just tie that in with probably about paragraphs 39 to 42, the unused prescription, the amount kept in people's homes, £110 million of stock, you know, drugs kept in people's homes. I'm just wondering what you can do about that. The pharmacy contract. And the third point, the Auditor General mentioned it, and anyone reading this I think would find this odd. The prescribing of drugs classed as less suitable for prescribing, and the difference between Lothian and Lanarkshire prescribe 5 times more drugs that are less suitable for prescribing. And if you look for a definition there, it says it doesn't mean they shouldn't be prescribed at all, but the evidence of their benefit is uncertain, and more effective drugs have superseded them, or they can have significant side effects. You know, financially, I find that, I know we're not the Health Committee, but from a financial point of view, I'm quite amazed after all these years to see such a disparity and such a cause of concern still existing.
Kick off with the first question about the community pharmacy contract, if I may, and then ask Tricia and Barbara to pick up from there. I think we've seen in relation to the GP contract how much scope there can be to improve the effectiveness of primary care and to align it with the rest of what the health service and indeed public services more generally are doing. And it does seem to us as a real opportunity to move the community pharmacy contract in the same direction. We're seeing some great initiatives like the Minor Ailments initiative that mean patients can register with a community pharmacy for the management of their condition. And we think there's scope to take that further by shifting the incentives from payment per item prescribed to something which is more about an effective and cost-effective prescribing. So the high-level recommendation is very much about using the ability to negotiate the contract to improve prescribing as part of the wider management of patients' health. Tricia, do you want to pick that up in terms of the specifics that we've seen and think can improve?
Mm-hmm. Yeah.
Paragraph, it does refer to England, 110 million, but I know there are figures, but perhaps not as much as that in Scotland, but maybe you have a Scottish figure that would equate to this.
Mm-hmm. In relation to the repeat prescribing service, one of the issues that was, or one of the risks that was identified was the potential that could mean that patients were getting their drugs perhaps more frequently, or some of their drugs more frequently than they necessarily would need them. So if you think, for example, of patients being prescribed painkillers, and they could be prescribed them to take them as required. So when their pain is bad, which will mean that they're not taking the drugs all the time, but it could be that under these kind of schemes that they may end up having a repeat prescription ordered before they had actually were coming to the end of the supply of drugs that they had already. So there's some risks in that that we are aware of, that we wanted to flag.
Pharmacy contract about to be renegotiated or changed or reviewed in order to address this issue?
I think there's some ongoing discussions around that, but we know that there have been significant changes to the contract already, around things like the minor ailments, over some chronic medication services as well. But we just wanted to flag up that issue around some of the repeat prescribing. Yeah. We're also, boards raised with us some of the issues around sort of public awareness campaigns, around making sure you're stocking up on your medicines before Christmas and things like that, when the practice is going to be closed. And again, as with the repeat prescription services, we recognise the value to patients there. But what we weren't then seeing was a tale of when people were stocking up for Christmas, but they weren't necessarily then cutting back on repeat prescriptions after that time. So you do potentially end up with some stockpiles there.
It's not just people that are stocking up. I mean, you're talking about care homes.
Yeah.
It seems to be very poor practice there as well. Could I just ask for a response to the second part of my question about the drugs classed as less suitable, with the evidence of their benefit uncertain and etc.
Yeah, I think as new evidence comes on stream, new drugs are developed and new trials and new research and things take place as well. So I think it's a case of making sure that things like the local formulary are keeping pace with the new evidence that's available. So, for example, we get drugs like cocodamol at certain strengths, which is a painkiller, where there's not clear evidence of the additional benefit that may have over paracetamol for certain patients, which would be a more cheaper and potentially more clinically more cost-effective alternative. Some migraine drugs, Migraleave, for example, are on that list as well. So there's a number of drugs. So it's not saying that they don't have any value, but it may be that they've been superseded by some alternative drugs. So what we think that the way to target that really would be through making sure that the formulary is picking up on the most effective drugs, and the prescribing support teams again working with GPs to look at making sure that there's compliance with the local formulary. So again, some of the disparity, if you look at Lanarkshire, we're aware that they have quite low levels of prescribing support in relation to some of the other boards.
So that would explain the low level of prescribing support and advice in Lanarkshire. That you're saying that would explain the fact that their prescribing of drugs that are less suitable. That would explain why that's 5 times greater than, say, Lothian and Borders.
I can't say if that's the only reason, but I think that would be one of the issues that they may want to look at locally. Would there again be scope to look at some kind of spend to save type initiatives there?
Okay, I'll leave it there.
Okay, Mr. Beattie.
Thank you, Convener. I have a couple of questions. Firstly, though, I'd like to echo the Convener's comments. This is really a very, very good report, probably one of the better ones we've had coming in front of us. But as the Convener said, we are the Audit Committee, so we have to look for something to pick on. I'm looking at paragraphs 19 and 20 in the main report here, where the comment is on the lower cost of drugs in the UK than the rest of Europe. And it is the UK we're comparing here, and I was quite intrigued by that. And reference is made in paragraph 20 to the comparison with insurance-based healthcare systems. Does that imply that state and private health insurance systems tend to be more expensive because they don't perhaps focus as much on generic drugs as on the branded drugs? Is that the case in Europe?
Is the case that there is more prescribing of generic drugs in the UK than in the comparisons we've looked at in Europe. We haven't investigated fully the reasons, but we think a key part of it is that the NHS gives us the ability to have to use all of that purchasing power that we have as an NHS with the drug companies through the price regulation scheme that's here. That's not to say that you couldn't have such a national negotiation in countries with insurance-based schemes, but they tend not to. It tends to be happening at a lower level with the insurance provider at a sort of regional level. So,
I presume in the UK context, in the Scottish context, there's no indication that the private healthcare system we have here, working alongside the National Health Service, is more expensive in terms of the drugs that they're using and prescribing within that.
We haven't looked at it as part of this audit. I'll check with Tricia and Barbara if there's any information we're aware of as part of it. No, we've simply looked at the way in which the NHS prescribes and particularly the trends over time.
It would have been interesting to see a comparison. I suppose the one thing that's missing from this particular comment is the actual volume of drugs that are involved, which would have been an interesting comparison. I suppose you don't have that.
I don't think the information's available to do it. We can do it within Scotland and within the UK because we've got the daily dosage unit to let you do it. Otherwise, we just compared spending overall across countries outside the UK.
My second question really relates to prescribing in deprived areas, and this committee has in the past focused on the more deprived areas of Scotland. And I'm looking at paragraph 72, where the comments made that practices in deprived populations prescribe on average 46% more drugs per head of population than in least deprived areas, and also that spending is also 37% higher per head of population. That creates a huge skewness in the way prescriptions and cost of prescriptions work, because the least deprived areas must be so much cheaper to compensate and give that sort of average that you're bringing out here. Given the fact that in the past we've discussed in this committee about the relatively few practices there are in deprived areas, would you say then that the relatively fewer doctors and practices in these areas are really prescribing way over every place else? And is there any more information around that?
There is some more information, and if you look on a little bit in the report, you'll see some of the things we've drawn out. First of all, I think it's true to say we know that patients who are receiving a high number of drugs together tend to be those in more deprived areas, as well as older patients. But secondly, when you look at the associations between deprivation and the prescribing of individual types of drug, it's not a consistent relationship. I'll ask Tricia to pick that up and tell you a bit more about what we do know about the relationships between deprivation and prescribing at practice level and more generally.
Again, there's very good quality data now available on prescribing and also on patient characteristics, which has allowed us to do this analysis for the first time. So what we found was the strongest relationship was actually with use of painkillers and then use of hypnotics and anxiolytics, which are things like sleeping drugs, drugs to control anxiety. We did still find a significant relationship with statins, so there is higher levels of prescribing of statins in more deprived areas, not as strong a relationship as for these other two groups of drugs, and we're aware that that is an area that boards are tackling. Again, it may be to do with issues we've discussed previously around perhaps the sort of later presentation, later identification, etc. But things like the Keep Well initiatives, which are health checks, are really aiming to try to focus attention on those areas.
I was interested in the comments you had in paragraph 75 about the prescription of hypnotics and so on. I mean, I presume that sort of uppers and downers and so on that are being given to people who are depressed and so forth. Is there a higher level of depression which is coming out of that?
It's not antidepressants, it's drugs for anxiety. So we didn't look at antidepressants for this analysis. They'd be a separate. That's a separate class of drugs.
I was just trying to really tease out some of the differences as to how the approach is in deprived areas versus the better off areas. There
certainly is other research that has shown a link between deprivation and depression and prescribing of antidepressant medication.
Thanks. Mr. Dornan, did you have a supplementary to?
It's on paragraph 72, and where it talks about some of the practices having a high number of cases, there's high levels of prescribing, but in the same areas there's sometimes very low levels of prescribing. Can you explain why this dichotomy and what we can really do to make sure that everybody's getting the same service?
I think we presented that really again to see practices can, with the support of boards, with the support of prescribing advisors, look at why that might be happening. So again, they can use the data to identify for particular drugs where you may expect prescribing to be a bit higher or a bit lower depending on the characteristics of the population that they're serving in terms of age, in terms of deprivation. Where things are perhaps looking a wee bit out of kilter, then for the prescribing advisors and the GPs to look at why that might be and see if there is scope either to increase prescribing in particular areas or to decrease it in some other areas. So it's making the point that, yes, where there's a very clear association, there still are outliers at either end where there's scope to do a bit more investigation locally to see what the issues might be and what could be done.
On the face of that, does it look like those that have got the higher levels of prescribing are getting a better service, or is it possible that the ones with the lower level of prescribing may be getting a better service because the pharmacists are using the drugs more wisely? Is that an unfair?
Yeah.
I don't think it's possible to give you a single answer to that. I think what might be more useful is to look over the page at Exhibit 16, where you see some of the differences around the individual drugs that are there. Tricia mentioned the fact that for sleeping pills and anxiety drugs, prescribing is about 4 times higher in deprived areas than elsewhere. If you look down a bit at statins, it's only 1.5 times higher. And given what we know about ill health in more deprived areas, about the lifestyle factors like obesity and so on that can lead to a higher risk of heart disease, I think it's a question about whether you might expect the prescribing ratio to be higher in those deprived areas, and that's an average. Within any particular area, practices are going to have a range. That's why we think the important thing is for the GPs to sit down with their prescribing advisors and use the data to say, we look a bit low here, should we be prescribing more of this particular class of drug, or we look very high on sleeping pills, is there something we can do to reduce that? It really is about targeting what's happening in a particular practice and over time working to shift that to make sure patients get the best possible level of care, whether that's more drugs or fewer drugs or just different drugs.
Okay, right, thank you.
Could I just come in? Sorry.
Yeah, by all means.
Could I just say that actually we are definitely not querying individual GPs' clinical decisions. That is no, sorry, but I just wanted to make that clear that that's their professional judgment. And what's very interesting in all of this, that Glasgow is looking one of the boards that's doing really well in terms of its management and support for GPs.
Okay, thank you. Mr. Kerr.
Thank you, Convener. My question actually heads back to this issue of overstocking, which perhaps may have been better as a supplementary, I suppose. And it is really along the lines of, over the past couple of years, we've had a few instances of absolute severe weather conditions. And allowing for the fact that in any industry, you have to sort of take this into consideration with the likes of the deliveries from suppliers and to the stockists, if you like. I was wondering, is there anything I've missed in this report somewhere that might take that into consideration if there, for instance, the severe winter weather that we had over the Christmas New Year period a couple of years ago? Is there any evidence that there would have been overstocking, shall we say, that's not been taken into consideration, but overstocking by care homes, pharmacies, which has skewed the figures slightly?
I don't think we have done that specific analysis of it. What we have seen and what we've heard from GPs, as well as research done in England, is that there's a consistent pattern of people using good schemes which enable them to stock up before a period like Christmas and New Year when the practice isn't open, so that you see the peak in prescribing, but you don't see the reduction afterwards that you might expect to see as the pattern catches up across the year. There may be something that Tricia or Barbara want to add to that. But I think it's a more general point about the incentives all being for community pharmacists to prescribe because of the basis of payment rather than to manage prescription in a more rounded way.
Yeah, it was just simply because of the fact that there have been some areas that perhaps the road was out of commission for the best part of a month. And if somebody's taking that into consideration, the higher it goes from being, in my opinion, where it differs from Mrs. Scanlon, is it goes from bad practice to actually good practice in terms of the ability to supply those people who require the drug. Yeah. And I was just wondering if there was something that...
It's not something we've got any evidence about, I think.
Yeah, okay.
Okay, thanks. Mr. Doris.
Thank you, Convener. I'd like to return to the variation between health board performances in terms of prescribing. Now, 14 different health boards, a dramatic difference, and one of the things you picked up on was prescribing support available. Are there any mechanisms in place to share best practice between the 14 boards, or any imperatives to say that they have to do this?
Tricia.
Yes, there's a Scottish prescribing advisors network think, not sure if that's quite the right title, but there is an umbrella group of prescribing advisors who do get together periodically, and part of that is sharing best practice and sharing guidelines and work that they're doing, etc. So there's quite an active network there. It's quite a small community, so they're quite switched on to what each other are doing.
And how long's that been running for? Do you know?
I don't know, sorry.
It's just that with still such dramatic differences, I'm keen to know how effective that's being. I should say it is such a good report. We're looking for ways to continue to improve. And I also sit on the health committee. One of the things we're finding from the EDTCs at each health board to put drugs onto formulae and look at all these things is quite significant variations in performance. So it's just, do you believe there's an appropriate mechanism in place yet, the one you mentioned? Because your report would suggest that the area for improvement is if we can get best practice across all 14 boards, there's still significant savings we have to make. So the structures that are there just now, are they working in relation of sharing best practice?
Yes, we think this is an area where there's a lot of good communication across boards. The joy of it, in audit terms, is it's so data rich. So we are very hopeful that by being able to highlight some of those variations, boards will take it seriously to actually look at what are they doing differently to some of their other colleagues. So we're hoping that this, in combination with the existing systems in place, will really help drive some of that good practice sharing.
Should the boards then be looking at a target to say if you were to return as a follow-up piece of work in 2 years' time and look at some of this data that the poorest performing board should be 40% closer to the best performing board? I mean, we have to monitor not just this is a snapshot in time, but where we are in 2 years' time or 4 years' time.
Yeah. As you say, like, this is actually a good news story, so it's quite hard to think of poorly performing and boards in that respect. But there are a number of indicators that we have tracked through from the very early days when we first looked at this. So it would be quite easy to actually take some of those indicators, excuse me, and actually look what happens in 2 years' time. It would be up to boards to select the areas that they want to prioritise, but there's some very clear messages in here for different boards about the areas where maybe they're not performing quite as well as other boards.
Okay, sorry.
Just one quick sort of example, I think, that we've been impressed by that may help to colour that for you. If you look at Exhibit 5 on page 11 of the report, you'll see that NHS Forth Valley is bringing down its spending quite fast. That's the orange line that's come down a lot since 2010. Now, Forth Valley tell us that they're achieving that by learning from what Greater Glasgow have been doing, one of the best performing boards in this area, and looking at the examples they've got of the areas to target, the ways of getting prescribing advice working in practice. So boards are learning from each other, but there isn't one thing that every board needs to do. It really is about targeting where they've got room for improvement and making sure that they're paying attention to that.
Okay, Convener, just one final question. I'm certainly not seeking to raid in the parade of what is a good news story, but it is our responsibility to go even further or to promote best practice to save even more money to the public purse and improve patient care at the same time. Now, on the other committee in which I sit, we've looked quite a lot at community pharmacists and the roles that they do. Now, I know there are specific initiatives in terms of improving prescribing methods that have been invested in by individual health boards, but community pharmacists are in every community irrespective of specific initiatives, and the ones that I meet tell me that if they had more time, if they had more space within their pharmacy, they would sit down and have that chat with customers, service users that come into the pharmacy to talk about polypharmacy and other drug and medication options. Is that something that you discovered within your report about, separate from specific initiatives, but just the community pharmacist on the high street that people are popping into all the time, you know, sometimes just for a lunch meal deal, for example, you know, if it's one of the large commercial operators, that they need more time to work with patients?
I think it's clear that there are some good initiatives in place already and that there's scope for that to go further. We know that good pharmacists can make a big impact on patient care, and there are good examples of it happening. I think it takes us back to the point that we make in the report about using the community pharmacy contract to put incentives in place for that sort of development rather than the incentive being payment per item prescribed. It's an area I think that's very variable because of the way the pharmacy service has developed over time. As you say, different premises, different levels of staffing that make it different in terms of what they could do in each part of Scotland. But there's certainly room to go further, and we think the contract is the mechanism to put in place incentives for that to happen.
Okay, thank you for putting that on the public record again. Thank you.
Thank you. Mr Griffin.
Thank you, Convener. The figures that really jump out from this report are that there's been an 11% reduction in the cost of drugs against the backdrop of a 33% increase in levels of prescribing, and a big part of that has been attributed to prescribing more of the generic drugs. And I would just like to drill a bit deeper into that, and I asked my question without an in-depth knowledge of the patent process and the approval process, so perhaps you can correct me if I go wrong anywhere, but it was just to ask if there has been any evidence of changes in the approval process for drugs to be made available for prescribing. Obviously, if there is a reduction in the time where a drug is available for prescribing on patent, then that will reduce the cost to the NHS. And I was just wondering if there had been any studies on the length of time a drug is now available on patent for prescribing as it was previously, and if there are any differences in Scotland and the UK and Europe, and whether that would explain the costs in Europe.
Tricia to give us a short tutorial on the drug patent system, if I may.
I'm not aware if it's any different, the length of time on patent. I wouldn't think it would be any different. I would think the patent would be for at UK level, so I can't think that it would be different in different parts of the UK, and I'm sorry, I don't know the minimum length of time that a patent runs for, but certainly you do see at the start of the period that we were looking at, one of the big drugs to come off patent was simvastatin, which is one of the very commonly used statin drugs. And if you look at our data, you see a sort of huge increase in the amount of statin prescribing that switches to being simvastatin when it came off patent, and you see the price dropping there dramatically. One of the other very common statins is atorvastatin, which has just come off patent now. So for the 7-year period, it was a proprietary drug, and so you see again there being kind of moves to reduce prescribing of atorvastatin where that's clinically appropriate for another statin to be used, because atorvastatin then is a higher cost option. Now it's coming off patent and we're seeing the price of it dropping dramatically, so again it becomes something that's more cost effective to consider. So it is something that does obviously have a very big influence. In terms of processes for introduction of new drugs, I think that was probably one stage back, because this is obviously looking at drugs that have already been in place for a number of years, where they've been through all the approval processes and licensing processes, etc. And it's just about them then having that time on patent. So the new drugs issues, I think, are a different issue, and not something that has such a big impact in terms of primary care prescribing at the moment, because what we see obviously is the new drugs that are coming through are at the moment the higher cost ones are more the specialist drugs that would be used more in hospitals and started by hospital specialists.
Can I just follow up on that? Nonetheless, you do in the report in paragraphs 62 and 63 refer to one of the aspects of the debate around new and expensive drugs coming in, which is the end of the price regulation scheme at the end of this year and the proposed shift to value-based pricing. And so I suppose my question is, you say these changes make it more difficult to forecast potential changes in spending and quantity of prescribing. So I suppose my question is this something which you think might undermine the progress that's been made and reported in this report?
Don't know what that will do to prices, so it's just flagging that up as an issue, as an area of uncertainty for the future.
Okay. On that, it's very brief, Mr. Doris.
I promise it will be, because we're looking at value-based pricing on Health Committee as well. In terms of the auditing that you would do, would you have to significantly change the methods of auditing that you use, given the fact that new prescribing of drugs, you'd be looking at the on-social cost of not prescribing in terms of social care, residential accommodation? Is that something you've been able to look at yet, or is that something you need more information from the UK government before you can start to address that?
As Barbara said, this is a very data-rich area, and that data, as far as we understand it, will continue to be available, which gives us the core of what's going on for both cost and the volume of drugs prescribed. But I think next time we may well want to look at the wider impact, particularly in things like care homes. We mention here the challenges of polypharmacy. Mrs Scanlon mentioned the risks of care homes overstocking drugs because of the things they're trying to manage. I think future work in this area we would want to open out and to look at some of those social impacts of either prescribing or not prescribing, and where the right balance might sit between them.
I think that would be interesting. Thank you, Convener.
Mr Coffey, you're always keen to find the positive, shouldn't be too hard in this case.
Thanks very much, Convener. I would simply echo your opening remarks in saying that this is a remarkable report, a very positive report, but we always look to see where improvements can be made, and the Auditor General has quite rightly pointed to a few examples where that possibility lies. I'm pleased to see in terms of the policy of the abolition of prescription charges that there hasn't been any noticeable increase in quantity of prescriptions being taken up. I think that's in the summary report that you gave as Auditor General. I suppose that could tell us a number of things, Convener. It could tell us that prior to the policy and after the policy, people, particularly in our deprived communities, or communities most in need, are still by and large, at the moment, taking up prescriptions and medicines before and after the policy. But of course the impact of cost in that is a significant one that should benefit those in those communities. My attention was drawn, Convener, to Exhibit 6, and it quite clearly shows in there, well, an interesting story, I think, in relation to Glasgow, NHS Greater Glasgow and Clyde. If you look at that drawing there, it shows that Glasgow is actually the best, though, in terms of the quantity of drugs per weighted head of population and the cost. So my question just now for the Auditor General is, how can that be such a good story for Glasgow? And it's very welcome, but given the high numbers of population SIMD zones we have in Glasgow that are fairly deprived. So on the one hand we hear about that all the time, Convener, that Glasgow has the highest proportion of these populations, but this performance from NHS Glasgow seems to be very positive. Could you help us explain that, please?
I'll ask Tricia to give you some of the details, but you're absolutely right. Greater Glasgow is doing a really good job here, and we know that some other boards, like Forth Valley, are learning from their experience. Just as a starting point, if you look at Exhibit 8, Greater Glasgow and Clyde are right at the top end in terms of the prescribing support that's available to GPs. They're actually fourth in numerical term, but given the scale of the board, they've got a very significant amount of prescribing support available to their general practice teams, and I think we're seeing the impact there. Tricia, can you pick that up and give us a bit more detail of what we know about how they're doing it?
Mm-hmm. Yep. They have, within their team, they have sort of a multidisciplinary team, so they have analysts. They're making very good use of the data that is available. I think there's some economies of scale there as well, because they are a bigger board, because they do have more staff numbers, so they are able to specialise in different ways perhaps to some of the other support teams. So they also are working with dietitians and other people who would have very sort of specialist knowledge of particular aspects of drugs as well, and really making good use of the data, working very closely with the boards, again being based in practices and working sort of directly with GPs part of the time as well, and quite a history of the team being in place over a number of years. again, they've introduced a number of Spend to Save initiatives, so they have sort of set quite clear targets. We will introduce these posts, but we want them to pay for themselves and make additional savings as well, which we can then reinvest in further improvements and further savings. So it's been, we feel, a very well targeted initiatives that they've got in place there, which the other are being shared through the national networks and being some of that good practice being rolled out in other places as well. The data are, it's based on weighted population as well, so it's taking account of things like the deprivation profile of the population.
You know, that's a really strong message, I think, and it chimes with what Harry Burns, I think, was telling us in one of our previous committees, that let's grab good practice, make it consistent across Scotland and share it as best and as quickly as we can. That's very important, I think. I wanted a second, if I could, Convener, the issue about the opportunities to save on waste. And one of the items that was mentioned there was saving on generic as against branded drugs. I think the performance on prescribing generic drugs is pretty good. In fact, a question that I asked recently on it, Convener, showed that 83% of drugs are generic, and that's an improvement of 10% in the last 10 years, as I understand it. The opportunity to make further improvements in that, I think, was set with the Auditor General around about £2 million, which very welcome, isn't a huge gain in terms of the overall cake. In terms of the recommendations you're making, Auditor General, about where we can save, how do we reduce things like waste when we're talking about drugs? Because I understand, Convener, that quite a number of the reasons, that there'll be clinical reasons why drugs are wasted. When people going into hospital, for example, don't, as I understand it, take their medicines with them and use them. You get new medicines, and similarly when you leave, and so on and so forth. How can our health boards actually make further improvements here when there may well be clinical reasons for this waste being in the system?
You're absolutely right. The performance on the prescription of generic drugs has been really good over the last 10 years, from a position where there was a lot of branded drug prescription that was hard to justify in either cost or quality terms, to something where the potential saving we estimate is very small. We give a figure of around 26 million available for further savings, most of which is due to either reducing waste in terms of repeat prescriptions, or drugs which are prescribed and not used, not taken anymore, or the category of drugs that Tricia was talking about that are classified as less suitable for prescribing. There isn't one way of doing it, and we think that most health boards have done some of the things that will make an improvement, but there is scope for doing more of it, learning from each other in line with the question asked by Mr. Dorris, and also reflecting the fact that this is a changing picture. Every year more drugs will come off patent, and there are more opportunities for shifting from a branded drug to a generic equivalent. New drugs become available which make some of the existing ones less suitable for prescribing. It really is about using the infrastructure that's there now in terms of prescribing advisors, formularies and so on, and keeping on using the data day by day. This is such a big area of spend, £1 billion a year, 1 million prescriptions every year, sorry, many more than 1 million, 91 million prescriptions every year. Keeping that attention on it as the situation changes is the way we think to both get the savings, but also to make sure patients are getting the drugs that they need to stay as healthy as they can.
Yeah.
Please, yeah.
Yes, by all means.
One of the other more recent developments in terms of the information that's available is that now almost all prescriptions have information on the patient's community health index number, so the patient's unique identifying number, which means it's now becoming possible to do much more analysis at patient level, so you can actually see how many people are having a number of different drugs prescribed, for example, how often they would be getting their drugs repeated. So again, that means that the boards and the GPs can work together to perhaps target some of these areas in terms of medication reviews, in terms of looking at people who are taking lots of different drugs as well. But that data set has only recently started to be linked into the prescribing data, and is giving much more powerful information to be able to look at some of these issues.
Excellent. Thank you.
Mrs Scanlon has a very, very short
Yes.
final question.
Yes, it was just on the point about saving money that Willie Coffey, to give us advice. And Exhibit 11, it's not surprising that the average spend on drugs by age group rises the older that people get. And I just remembered, as you were speaking, the Mental Welfare Commission telling the Health Committee that over 70% of people in care homes were on antipsychotic drugs. Many that were not necessary. How would you advise us to, because many people don't see their GP and the pharmacists don't go into care homes. So I'm just wondering, is there a missing link here that should we be looking at a way of saving money for that group? How could it be done?
I think that again is very much through the medication reviews and looking at what is the variation, is that appropriate variation? But I think that's clinical judgments. So again, it's not for us to comment on clinical judgments, but for prescribers with support from others, really to be looking at to see whether or not that is always appropriate. And I'm aware that organisations like the Royal Pharmaceutical Society have recently issued sort of guidance around care for people in care homes and where that could, where they feel there's scope for improvement there.
Okay. Well, thank you very much. Thank you to our witnesses. And later we will have the chance to consider how we take this report forward. Thank you very much. We're going to change witnesses now and change to a different though related topic. So I'm going to break for 5 minutes just now while we change witnesses and for a comfort break. Let's reconvene and welcome our next panel to give evidence. This is evidence on the Section 23 report, Health Inequalities in Scotland. And so we welcome Professor Graham Watt, who is a Professor Graham Watt from the University of Glasgow, who is also the coordinator of GPs at the Deep End project. Dr. Susan Langridge, who's a GP at Postle Park Health Centre. Dr. Peter Cosson, who's a GP at Drumchapel Health Centre. And Elaine Eggleston, who is a health visitor at Govanhill Health Centre. And invite the panel if any or all of you wish to make some introductory remarks.
Thank you very much. I'll just make some remarks from a deep end point of view. The first thing is to say thank you very much for the opportunity. We are very grateful for that. I think I should also say at the beginning that the deep end group of practitioners, 100 practices scattered across 10 administrative areas, had never met or been consulted by anyone until 2009, and we're grateful to government for having provided the funding that made that possible, providing locum funding for a series of meetings. That was absolutely key. So while some of our comments may be critical of government, we are very appreciative of the fact that we wouldn't be here but for its support. We're also grateful to the Public Audit report on inequalities for covering an issue which has been very important to us for since our beginning, and which we feel has been rather neglected in the scheme of things. There are some aspects of inequalities in health that are described as complex and new, but what we're talking about is gross and long-standing. And I'm talking about the distribution of manpower. There are a couple of things that we would wish to comment on in relation to that report. One is the exhibit on manpower data, which we think is potentially misleading and has already been misquoted on at least 2 occasions in evidence to committees. And we also think that the audit report overestimates what can be achieved by the QOF as a solution. Happy to come back to both of those points. We would like to say that in the scheme of things, I think one applauds where the government is on its approach to health inequalities by focusing on the early years. It's 35 years since the Black Report encouraged governments to invest wholesale in the early years, and it's good to see this now turning into policy. And clearly the aim of that is to create a population that is healthy for as long as possible, what's called healthy life expectancy. But when healthy life expectancy comes to an end, people acquire conditions which they live with for the rest of their life, and the job of the health service is to enable people to live well and long and as independently as possible with those conditions. And one of the observations we would make is just the reluctance, I think, to acknowledge not only the role of the health service in doing that, but the consequences of the health service not doing that. I think you've had a number of rather dismissive statements as to what the NHS can achieve in relation to health inequalities. And in terms of the origins of health inequalities, one would agree with that. But in the second half of people's lives, the health service is a major resource for altering the natural history of people's experience. And if the health service doesn't do that well, where needs are most, then the effect of the health service will be to widen inequality. And we think there's been insufficient acknowledgement of the potential for the health service to do that. I think it's rather unimaginable to many people that the health service, which is not meant to do that, could do it. But the consequences of some of the data we presented to you, I think, have that conclusion. Healthy life expectancy ends, according to ISD, in men, in the most deprived tenth at the age of 57, and in the most affluent tenth at the age of 76, which is a 19 years difference. And for women, healthy life expectancy ends at the age of 61 in the most deprived tenth, and at 78 in the most affluent tenth. And in the deprived areas, people have 10, 12, 15 years left to live with the conditions that they have. In affluent areas, they have 5 or 6 years left to live. So the difference in life expectancy come round to about 10 or 12 years. And in relation to the QOF, recent data from ISD, based on consultations from representative Scottish general practices, show that only 12% of consultations in general practice involve a QOF condition. So 88% involve other conditions. A paper in the Lancet last May on multimorbidity in Scotland, based on 350 practices, showed the epidemiology of multiple morbidity, which is the norm in people above 50. This is 2 or more conditions, a very simple definition which underestimates frailty in old people and social complexity in people in deprived areas. But having 2 or more conditions is the norm in people above 50. It occurs 15 years earlier in deprived areas. The commonest comorbidity is psychological problems, which accounts for some of the prescribing data. And although multiple morbidity is commonest in old people, because we've all got older relatives with lots of problems, actually most people with multiple morbidity in Scotland are under 65 because of the demography. So this is the burden that the health service is challenging. And the point that we would like to make is not to look backwards at the inequalities that we've singularly failed to address for 20 years, but to look forwards to a population that's getting older, that has multi-morbidity. This paper in the Lancet showed that of all of the QOF conditions, there wasn't one where people who only had that condition weren't a minority. The majority of patients had 2 or more conditions. For example, of the diabetics, a fifth were on antidepressants and a fifth were on prescription analgesics. So whilst the diabetologist is the man to see for your diabetes, he might not be the man to see for your depression and your chronic pain. And that's true for every major chronic condition. So we're dealing about multiple morbidity, which for patients is hard work, dealing with different drugs, regimes, clinics, doctors. And the challenge is to live well with that. The health service, I think, needs to gear up to provide a more integrated experience for patients with multiple morbidity. It can only be done by generalists. It can't be done by an army of specialists. And that work clearly has to be done in general practice. And if it's not done best in deprived areas, then the net effect will be to widen inequality. So we see this as an agenda really for the whole of the NHS. It just happens to be especially important in deprived areas. We focused on the 100 most deprived for pragmatic, arbitrary reasons. But leaving aside the particular problems of deprived areas, such as the high prevalence of mental illness, of alcohol and drug misuse, and vulnerable families, the main difference is simply the volume of the multiple morbidity that practices are dealing with. We think the solutions are the same, but they need to be prescribed pro rata across the board. Deep end practices serve areas of blanket deprivation. There are many other deprivation pockets in other practices. The situation has to be addressed pro rata. We don't want to be portrayed as arguing that the answer to all these problems is more GPs. That's clearly not the answer. GPs in deprived areas do need more time, more capacity and slack in the system to cope with the problems that their patients present, invariably in an unpredictable way. But they also need to be linked better to all the other resources that are around them, whether it's area-based NHS services for mental health addictions or for child health, and also for the resources that exist within communities in terms of voluntary organisations and all the community assets that are described. We need a joined-up approach to these future problems, in which the main hub can only be general practice, because that's where the health service has got its contact with the public, not only the contact, but coverage, continuity, flexibility, relationships, and trust. There's no need to look for those things anywhere else, because that's where most patients have that. It's under-resourced, it's not reaching its potential, but it is, we think, the answer to the problem that the health service faces in the future to prevent inequalities widening later in life. And I think with that, I will probably just make one final comment, and that is the intervention here isn't a single intervention. The last 20 years is littered with short-term interventions which have all been about the beginning of something, screening for this, screening for that, lacking the follow-through which is required to help people live with their problems and survive longer in the community and make less use of emergency services. We think we need to be investing in the serial encounter with patients, so that that serial encounter is a productive relationship in which patients acquire the knowledge and confidence to live better with their conditions and to make better use of the resources around them. In affluent areas, people are up for that straight away. Self-help and self-management they're up for it. In deprived areas, it's a longer haul, and the system needs to recognise it's a longer haul going down that road in these areas. I'll stop there. Thank you very much.
Okay, thanks very much. Do any of the other witnesses want to add? By all means.
So first of all, again, I would like to just thank you for giving me the opportunity to come along today and speak to you from the front line. Quite often, I think perhaps that what's happening on the front line is filtered through our managers, and it's good to get this opportunity to come and say about how I and my colleagues in Govan Hill, and I must stress that I'm not speaking for every health visitor in Scotland, but obviously knowing that I was coming here, I have discussed this with my colleagues, the kind of things that we would want to bring to your attention. So it's a great opportunity for me, but it's also a great opportunity for you, our legislators, to know how your policies, government policy, are translating locally and what that looks like for us at ground level. I would pick up on what Professor Watt was saying around about the early years. Obviously, as a health visitor, that's exactly where I'm working. I've just chosen a few examples because I can't really go into every aspect of the job that I do. But one of the simplest ways that we can address health inequalities within deprived areas is through infant feeding. And until fairly recently, approximately 1 year ago, things changed. But we in the southeast of Glasgow had a very, very supportive Cell 36 infant feeding team. They were available to us and they were available to the families. They could go in and support mums with their breastfeeding on the same day that you asked, and the maximum we ever waited was 3 days. The central team now are less accessible, and we're seeing that our breastfeeding mums are not feeding for as long. Now, we know the impact of breastfeeding in terms of long-term health gains. Approximately £17 million per cohort year could be saved just with reducing the treatment and hospital admissions for 4 conditions alone. That's ear infections, necrotising enterocolitis, other gastrointestinal infections and lower respiratory tract infections. Just those 4 things, £17 million. So that's a massive thing for anyone to be able, a massive amount for anyone to be able to save. And we feel that just as we were getting up and running, just as this was beginning to work, the Cell 36 money was gone, and so did our team go. And so now we have one individual for the whole of the south of Glasgow who her sole job seems to be audit and spreadsheets. She has the knowledge, but she doesn't have the time to come out and to support mums. So that is a really big thing for us. I personally was involved in setting up a breastfeeding support group at the New Victoria Hospital in the south side of Glasgow. The New Victoria is great, but it's not necessarily the most accessible for families who don't have their own transport. It's just outside of Govan Hill, which is a very diverse population. For any of you that know Glasgow, it's very culturally diverse and really quite severe deprivation. And then we go out a wee bit further and you've got East Wren, who you'll know again are much more affluent. And they don't have resources either, so they send their mothers to us. We have a tiny little room, and we have actually had to ask people to leave because for health and safety reasons we can't have all these people in this small room. So they're just in one example of infant feeding, there's an ability to address health inequalities within a deprived area. There's also the opportunity to address cost issues around about associated infections of not breastfeeding, and around about resources in terms of what we have to work with to provide the best service possible. We, as health visitors, are really good at what we do. We have gone back to university, we have done 2 years extra training. We are good at what we do, but we need support to do that, and we need it from government level, and we need that to translate locally into what we're doing. And I'll stop there.
Okay, thanks very much. Anyone else?
I could just pick up on both of those speakers. I've been a GP in Drumchapel for 14 years. It's a very rewarding place to work, and I think the real strength that we have to talk about is the issue of relationship and trust. Early years don't happen in isolation. The mother of the young child often is supported by a grandparent who often has the kind of conditions that Graham was talking about. The home situation might involve issues with alcohol or lack of employment or anxiety problems, a whole lot of issues that the mother faces. And I think the real strength of the primary healthcare team is to have excellent health visitors, excellent district nurses and GPs and practice nurses who know each other. And I think that relationship and communication is a key strength that the primary healthcare team brings. And I think the other thing that we bring is that relationship with patients over a long period of time. Over 14 years, the early years become the mothers themselves. I think that actually one of the underused resources in the NHS, or the least understood, is not the drugs that we prescribe, but the relationships that are built up between the team members and with patients. And I think looking to the future, unless we have trust and relationships of this type and the time to develop them and to use them effectively, then we'll simply have lots of activity where we're simply signing off that we've done what we have to do rather than actually effectively making a difference both to people's quality of life and to their life expectancy. And I think it's in deprived areas where those relationships are most important because people are at their most vulnerable and least able to make use of services without the feeling of support and relationship.
Okay, thank you very much. I wanted to start with the written evidence submitted by the Deep End GPs, much of which I think is extremely powerful. The opening paragraph in particular talks about the flat distribution of general practitioners in Scotland in contrast to the gradient in health needs, and says that this is the principal cause of the inverse care law in Scotland, that the more care you need, the less likely you are to get it. A partial explanation of 20 years of failure to address inequalities, and a major obstacle in searching for effective, affordable ways of delivering the care that we need. And the paragraph ends by saying the status quo, maintaining that flat distribution of GPs, is a recipe for widening health inequality. So you said, Professor Watt, that your argument was not an argument for more GPs, but it must surely, in that paragraph, be an argument for more GPs being placed in the more deprived parts of Scotland. Is that correct?
There needs to be more capacity, but I don't think we need to be importing new practices or new places. We need to build around the practices that we've got because of the cumulative knowledge and experience and relationships that they've got. The most valuable clinical time in practices is that of the experienced GP. So although training is an attractive option, and there's an argument for that, and also for fellowships, as there are, if there was many fellowships for working in deprived areas as there are for rural areas, that would be a good step in the right direction. But essentially, one of the things that we need to harness is the experience and commitment of the experienced general practitioner. You know, both my colleagues here today will be having a locum back in the practice because they're here, but the locum will only do some of the work. There'll be additional work to go back to in terms of catch-up, and that's because just simply providing an extra doctor isn't necessarily the solution. So we are not arguing that the shortfall in manpower simply needs to be corrected. I think there needs to be a halfway house in that direction, because doctors on their own can't address all of these problems. They need to be linked to other services, and often they're only the signpost at the beginning of a process. Although a starting point is the flat distribution of GPs, and we think that needs to be corrected so that it is at least a slope. I think the effectiveness of additional GP time will be enhanced by improving the links to other services, and it's that joined up approach that I think needs to be imagined and pursued. And it's not just for GPs to imagine it, I think it's for the whole service in local areas to imagine it. And one of the things that the Audit Committee reports is that at a local level between CHIPS and general practices, the relationships are often quite dysfunctional. And if you applied the relationships that you can observe between different levels of the health service to the patient relationship, it would be completely unacceptable in terms of the quality of communication and the extent of mutual understanding and respect. Can I comment on the numbers in the report? Because they have been misquoted. Derek Feely says that...
Can I ask you about that? Because I think I did want to ask you about Exhibit 13 in the report does show that there is a slight reflection of levels of deprivation in the distribution of GPs, but the report also makes the point that there is no data available on whole-time equivalents of GPs, and I think Audit Scotland are clear that they would like to see that data. We've asked for that data from the NHS, from the Scottish Government, and they've told us that it's not available. But in your evidence, in the deep end evidence, you quote some data which goes back some time, but you make the point that nothing has happened to change that. And if I read this data correctly, you're saying here that in actual fact, far from the distribution being flat, that there are more GPs in the more affluent parts of Scotland. Is that right?
Slightly more. I mean, you asked for whole-time equivalent data, so we've given it you. It's the most recent data from 2003, before government stopped collecting the data. I think that wasn't a deliberate decision. It just happened as a result of the new contract, which engages with practices rather than individual doctors. But it means that this crucial bit of information, which previously really wasn't valued, hasn't been collected. And if you look at the 2003 data, let's just say it's flat. You know, it's actually, if you add in the training posts, it becomes slightly biased towards affluent areas. The data that Audit Scotland got hold of from ISD are based on a voluntary and therefore partial survey in 2009, which is based on numbers of GPs and not whole-time equivalents. So when you look at the table, it's very difficult to interpret. If you compare these data from 2012 with the 10-year-old data on whole-time equivalents, the thing that jumps out is the numbers in the least deprived areas, which are very much lower. If you just looked at the quintiles 1, 2, 3 and 4, it's pretty flat, I would say. Very small differences. Impossible to interpret, because these individual GP numbers could be somebody who works whole time or 2 sessions a week. But we would make the point that you know, what has happened in the last 10 years to shift that distribution? There's been no policy initiative to do that. And the final point is that I think when a couple of people have been quoting about 25% more GPs in deprived areas than, or 40%, it seems to be on the basis of comparing the quintile 1 with quintile 5, and there's a big question mark over the data for quintile 5. I would take these data from Audit Scotland as showing that there's a question mark about whole-time equivalents in the most affluent quintile, but otherwise the data are consistent, although less precise, than the data we showed 10 years ago based on whole-time equivalents.
Okay. I mean, we are the Audit Committee, and in the work that we've done on this issue, the NHS would say to us that in the and Audit Scotland would acknowledge this as well in their report, that some cognizance is taken of levels of deprivation in the distribution of resources to NHS boards. However, Audit Scotland have also said to us that they cannot find any evidence of how that distribution then feeds down to the front line, as it were. So is it fair to say that you're saying there is evidence that that additional funding is simply not feeding down to the front line because it doesn't reappear in a distribution of GP practices which would match healthcare needs?
Well, I think that the comment I would make is indirect, is that when you start looking at activity, or Stuart Mercer's study of 3,000 consultations in the west of Scotland, affluent and deprived, not such a wide range as the whole of Scotland, and he shows that the length of the consultation is actually shorter in deprived areas despite the higher level of multiple morbidity. The consequence is that patients are short-changed, they're less likely to be empowered by having seen the doctor, especially if they have a psychological problem, and the practitioners report being under stress, because after each long, complicated consultation, there's another one waiting, and another one after that. The Kippock practice in Postle Park, which is the most deprived, who wrote an article about their experience, said the main thing about our practice is that we have more difficult cases, not necessarily different kinds of cases, but just a bigger volume of them. The PTI data on consultation rates, when you apply the figures produced by ISD to Scottish general practices, they do show 15% higher consultation rates in the most deprived fifth of practices. And in relation to the manpower data, that can only be achieved in one of two ways. One is to work longer hours, and two is to spend shorter times within each consultation. So what you get is incomplete encounters which lack the potential to address a patient's problems. The patient's experience is fragmented. It's a series of stop-starts. It doesn't enable the primary care team to work with the patient and to engage productively over a series of longer encounters. There is work ongoing, which will be reported in the next 3 months on the effective extra time on consultations for very complex patients. So there will be some evidence, but in general, you know, the reason why the QOF is what it is because that's what the evidence is based on, single diseases. It's only very recently that research has turned its attention to looking at the issue of multiple morbidity. Almost the entire research establishment and literature and guidelines and policy is based on the vertical approach to cancer, heart disease, mental health, not on the individual who's got all three.
Can I ask Ms. Eggleston whether, when it comes to professions such as health visitors, if your sense is the same, that there is additional resources which are said to be provided at a board level are actually producing more health visitors in areas where that additional need is found, or is that also flat?
It's not something that I've noticed that there are more health visitors. The only qualification that I would make to that is within Governhill, as I say, we have a very multicultural community, and within that we have a high EU population, and we have a separate EU health visiting team. And they do have very high levels of deprivation and have very specific needs. And that team are certainly kept very, very busy, but it's one health visitor and 2 support workers to do an awful lot of work.
Okay. So, I mean, in terms of chasing the resources, it is the case that additional resources, we are told, are provided at a board level, but that at the front line, patients in areas of deprivation are, and these are your words, Professor Ward, being shortchanged. Is that?
I think in relation to the legitimate expectation that their needs would be met. I mean, the NHS is about comprehensive healthcare based on need, free at the point of use. The rhetoric is clear enough.
Yeah.
I mean, and I think there needs to be maybe break down the health service into its bits. You know, emergency care is very equitable. A&E, emergency hospital beds, but it's too late in the day for most patients in an emergency bed. But it's very equitable how it's provided. There are no credit card checks at the front door. Access to specialists is not equitable. You've written about that as a consequence of the Cardiology Committee, and is not a simple issue to address. The issue that we're addressing is the inequity in what I would call serial care. You know, once you start to acquire conditions, that's going to be part of your life, and you know, hopefully not a great impediment to your life, but it is a new part of your life. And I think an analogy can be drawn with the early years policy about giving people a good start at the beginning of their life. Well, when they start to acquire conditions, they need a good start in being knowledgeable and confident about living with those conditions. So I think we should apply the same kind of approach, because at the end of the day you want individuals to be confident, knowledgeable, to have a sense of coherence about themselves, not shifting from one crisis to another. And the system doesn't allow people to get past base in that journey.
Okay, thank you, Ms. Scanlon.
Can I come in here? Sorry. Just to echo this, I apologise to the committee. I've got some virus, so I don't normally cough and speak like this. Just to echo the thoughts that have gone up, the difference with the deprived patient and the affluent patient is when we talk about an assets-based approach, which I'm very much in favour of, I'm moving towards self-management, is that the deprived patient isn't at the stage of being able to use their assets. It's not that say they're not there, but there's a process that needs to be gone through in order to get them to understand, recognise, and to be able to then use their assets. So there's a lot of work that can be done with people to get there, but within the primary care health team, you need in order for the assets-based approach to work, you need to do the work behind that and do it within the primary care health team, because that's where these patients come to. We are the people, as Peter's pointed out, the patients trust. We have the serial encounter. Generally, these people are very fearful of unknown, and we are the people who will guide them through this process with the health visitors. And so the resources need to get targeted and need to continue. And that has been one of the historical problems, is there have been resources. I've been involved with Keep Well from its inception, which has been a very good scheme. But the resource dwindles and gets fragmented and moves away. And that's, from where I sit, where the bit of the issue lies.
I just wanted to continue on the line of the convener. We're discussing Exhibit 13, and I think you questioned the figures there. But I would also like to look at Exhibit 14 and 15, because 14 illustrates that there are over twice as many pharmacies in most deprived areas than least deprived, and also the distribution of dentists. There are almost twice as many dentists in the most deprived than least deprived. Would you question those figures, or you're talking about the integrated healthcare team, and I'm seeing both these professions as being part of that health team?
I think the patterns in Exhibit 14 or 15 are what one would wish to see. I'm not an expert on manpower for pharmacy or dentists, but I suspect that they're easier to distribute than medical manpower. For quite a long time, the flat distribution of GPs was actually policed by the Medical Practices Committee, by GPs themselves, in order to maintain what was seen as a level playing field. And that really wasn't addressing a public health agenda. It was protecting a view of the world in which practices should be equally rewarded for being busy. And of course, all practices are busy, but they're busy with different things. We make a point of not claiming that GPs in affluent areas aren't busy. They're very busy, partly because of the demography of the practices, but also because their patients are very demanding. They want more time to discuss things and to come to a decision. But insofar as they're busy, they're more busy dealing with demand than dealing with need. So the desire for more time is ubiquitous, but it's for different kinds of encounter, and encounters which contribute to differing extents to addressing the issue of health inequalities.
Yes, I appreciate that, but I also appreciate within the 14 years that this Parliament has been set up that the pharmacists now offer health checks, smoking cessation, and various other services. And I think every pharmacy in the country has its own consultation room.
Yeah.
So I was just wondering, with over twice as many pharmacies, apart from the dentists, that, was that acting as a support to the GPs? Well, that was my point.
Clearly, it will be. I think there is a general problem that the health service has too many services which see themselves as hubs, as centres of activity, when actually they need to be joined up, because the patient needs to be at the centre. And when the patient has several problems, the pharmacy may be the place to go. Sometimes the general practice is a place to go. Looking at PTI data again, we showed some years ago that 13% of patients account for 48% of encounters. So there is a minority of patients who generate half of the work of the health service, and my conjecture would be is that they are the patients who most need a personal doctor over a period of time.
So can I ask you, do you think that the pharmacies are joined up, given that they offer a minor ailment service, health improvement services, smoking cessation and long-term condition support? Do you feel that they are signed up and integrated with the GPs?
Yeah. I think, can I just answer that from experience rather than speculating in general terms? I think our relationship with our pharmacy over the last 10 years has changed beyond recognition, so that the local pharmacies are now work much more closely with us, and we have a local pharmacist who comes into the practice several times a week. We have a blood pressure clinic of our patients booked on our appointment system, but in their pharmacy. So yes, absolutely, I think there's been a transformation in relationship with pharmacies. I am concerned if this is going to come to appear that we're simply here to say there's not enough GPs, we need more GPs in deprived areas. For me, the key issue is the question of what does the primary healthcare team have to contribute to health inequalities and reducing health inequalities. And my experience is that it's not even being considered as part of the picture, that health inequalities has been thought of as being something that's done out there, and then the health service does something over here. And I think what I passionately believe is that we do make a difference to people's lives, we do help to reduce inequalities, but that there are very limits to that, and that if we can do that better, then we can have a much bigger impact on people's lives. That's not just about numbers. I think there are things that we in the practice would love to do more effectively, and we have ideas about how we might do it, but it's a question of getting from here to there in doing that. And what I don't like is health inequalities initiatives that have little to do with the frontline health services and are done in a short-term fashion. And over my years, I've seen quite a lot come and go. And I think it's about saying, I would love to work, for example, have a social prescribing advisor in the same way as I have a prescribing advisor, someone that comes into the practice who perhaps some health improvement or public health has that same relationship, who knows what's going on in the community, and so that I have an alternative. At the moment, my choices are either prescribe or do it myself, and very often I do it myself. I give people large amounts of time to deal with their distress, their domestic violence, or what have you, because they won't go anywhere else. And that's at quite a high personal cost in terms of stress. And I think that what we need is to help practices develop an alternative within the community to build relationships with local assets, what's going on in the community. So why not have a close relationship with health improvement in the same way as we have with prescribing, so that we can work with them in that way. So I'm very keen this doesn't just focus on numbers, because like I said, I think this has to do with quality and relationships and improving the effectiveness that we have in deprived areas, because I think that that can impact on inequalities, not just life expectancy, but actually happiness and lack of suffering, because the real inequality isn't dying younger, it's the quality of your life before you die. And I think that's where we need to be able to focus more on that, and perhaps not get completely tied up in just manpower and numbers. Thank you.
Can I just say, having spent about 8 years on the Health Committee, I've got to keep reminding myself that we're not a Health Committee, and so we've got to be careful. I mean, the Health Committee do an excellent job, and we should not really tread, and we're looking at the public spend and value for money, addressing inequality. So really a question to Graham Watt. I'm sure you remember in 1999 coming to brief the Health Committee on the Arbuthnot formula, which was looking at poverty and deprivation, and really to make sure that areas like Glasgow and others received the funding that they needed. The Arbuthnot formula 1 and 2 then became the National Resource Allocation, but I know, Professor Watt, that you've been involved in tweaking this formula from Labour Liberal Executive to the Scottish Government to ensure that deprived areas got the funding that they needed. And so my question really is, given your position of influence, did you find that although you got the formula right, let's say for Glasgow, were you concerned at the point you were discussing with the convener that the formula right or wrong? And is the problem that the Health Board gets plenty funding, but it's not being distributed according to the formula?
Well, I think you exaggerate my input to the resource allocation.
I do remember
process.
1999.
It wasn't for the want of trying.
Yeah.
There are some things. I mean, we had the best data, the best statisticians, and the best methods. So we were starting off in a good position to try and distribute resources equitably. The problem was that the data wasn't as good as it needed to be. If you were simply, because you needed to measure need. In hospital activity, it's fairly straightforward. You just count up the admissions, because there's nothing to stop emergencies getting admitted to hospital. So need is reflected in use. The situation that we've described in general practice is that there aren't enough hours in the day to address need. So the unmet need by definition is not represented by activity. So if you use activity data like the PTI data on consultations to assess how busy a practice should be, and then to rectify the difference between that and what you observe, the elephant in the room is the unmet need. And that problem is always going to exist. The later committee, was it the NRAC? They had a special look at unmet need, and they commissioned a team of health economists in New York to see if they could find evidence of it. And my recollection is that they concluded that they couldn't find it, and that was because they were sitting at a desk in York. If you're sitting at a desk in Govan, unmet need stares you in the face every surgery, but it's not recorded in the data that was available to the process. And I think that is largely still true. And it's not it wasn't for the lack of intention, because if the Arbuthnot report and the successful report had been able to produce a formula that would have addressed that issue, they would have. But we're in a situation where the resources that are available are not able to generate activity commensurate with need that can be used as a proxy for need in these formula.
Just my final question, I don't want to leave the health visitors. We've actually had quite a lot of evidence in this Parliament from Dr Phil Wilson and others on health visitors in Glasgow, and also from the Chief Medical Officer last week on the importance of the early years. I think we're all signed up for that. My understanding is that there have been significant changes to health visiting, and I know the area I represent in the Highlands, I think withering on the vine was the way it was described to me, and I hope I'm not being, that was what the health visitor said. But is health visiting funded to look at the most important years of life and to support the mothers? You know, is that where, I think we were told by Phil Wilson, if you want to address inequalities, you get health visitors and you look at the early years. Is that right, and is that happening? And is health visiting still alive and well in Glasgow, attached to the GP practice?
I would say that health visiting is alive and well in Glasgow, and I personally like being GP attached. Everyone will always say that they could do with more, that they could do with more money, they could do with more staff. And recently within Govan Hill, we are seeing more staff coming to the team, but not more health visitors. And to be honest, we are a little trepidatious about what the rumours that we're hearing, what road the health visitors, or the role rather, that health visitors are going to be having within this team, because it sounds as though we are going to be handing almost our whole role over to staff nurses, nursery nurses and support workers, and we will manage the team and we will deal primarily with child protection. We have gone to uni again, going back to university. We are all either midwives, we have paediatric, I have paediatric and neonatal experience. Every health visitor has more than one qualification, and usually it's midwifery and a registered general nurse. So we're bringing a lot more than just a specialist qualification to the table. We're all bringing a lot of experience, and that's not always just about clinical experience, that's about life experience and being able to identify with our families. So from our point of view within Govan Hill, we see a lot of money spent on a very small portion of the community. We would appear to be importing a lot of health inequalities and putting a lot of resources into addressing that very small population. And there is a feeling that we may be ignoring the majority of the population who are more likely to remain here, so we may actually be addressing health inequalities on behalf of other countries.
So just a final, so are you seeing, I know it's alive and well, but is there a universal health service, and are you moving towards an integrated team that would be more beneficial or not?
An integrated team in relation to the staff nurses, etc.
Supporting young mums, whatever.
We have now got the nurse practitioner, the small health visiting team that's going to take on the most vulnerable, the young mums. That will remove some of the more challenging families.
Who's being left out?
Who's being left out of the...
Well, you said you would be focusing on one group. And
yes, there is a small population within our community, the EU population, have a massive amount of money spent on them. I believe that money comes from Europe. They have a high level of need. That money is making a difference, but then they go back home. And there is a feeling within the community, there's a feeling from us as professionals and also families that we visit who will comment on how much is available locally within the centre of Govan Hill. There is Daisy Street Community Centre, and there are lots of things run for the Eastern Europeans. There's very little run for the Indigenous populations or the Asian. There's a high Asian population in Govanhill. There's not nearly as much available for them. From our point of view, there are lots of things that we could and should be doing for our families that we can't because we don't have a room to do it in. We have to buy time at Daisy Street. We have to buy time from the church. And so there are lots of things that we could and should be doing. Everything that's available for our Indigenous population is available elsewhere. For example, we have no under 3 resource in Govanhill. If we identify a family with need and they have a child under 3, we have to send them to Pollock-Shields or to the Gorbals. Now, we're talking about deprived families here. We're also talking about families who, for various reasons, may not have the greatest motivation, and we're asking them to take their child or children down to another area. When we're identifying Govanhill as being an area of deprivation and an area of need, and we have nothing there, there was, within Startingwell, there was a nursery set up. It was more for relief that you could, for a short period of time, almost like the PACT team do at the moment. So for a short period of time, if you identified a family with need who had that support level or needed that level of support, you could ask them to attend this group. That gave us an opportunity to actually deal with more than one family at a time. So if that's running for 2 or 3 hours in the morning, within that time, we're seeing a lot more families. You're making much more contact, and also you're starting to build networks for the mums to go out and then continue to have that support and to see that they're not alone and that you're not being judgmental of them, that what you've got to say to them is not personal. So there are lots of areas that could be improved, but they do need money. But I have some ideas where you might save that.
Thank you.
Okay. Mr. Dornan.
Thank you, Dina. Can I just say at the outset that I wasn't part of the committee when this piece of work started, so obviously this is the first time that I've came across any. I was very impressed by the powerful submission that you made and also by your introductory remarks. I am an MSP for the neighbouring constituency from Govanhill, so I know the problems that Govanhill face very well. I think that MD who stays in Govanhill or in the City of Glasgow deserves the same level of service as anybody else does. I used to be on the South East CHCP, so I do know that more money was put in to deal with the unique circumstances, and they are unique in Govanhill. So I'm not sure that should impact on other people staying within the area. On the general point, what seems to be coming across here is partnership working is really important. I mean, Dr. Kant spoke about it, as did yourself, Professor. Given the new position of the community planning partnerships in terms of health inequalities, can you see them playing a role in general in terms of maybe trying to pull together some of the organisations that are required to work together, that should be working together to make sure that health inequalities are combated? And also on the general point of the breastfeeding, could you see, I mean, it is meant to be about local priorities, could you see something like that benefit from the work that should be done through the community planning partnerships?
Can I comment on the integrated care agenda? There was a deep end report available on the web on integrated care, which was our response to the government's consultation on integrated care. And we ignored the first 15 questions because they were all about people sitting around tables in headquarters, which is a continuing challenge, and it may or may not be addressed this time. We were much more concerned about what was happening at ground level, at area level, where it does depend on relationships. In a sense, the thing that needs to be built up is social capital, quality of relationships. So one of our wishes and proposals is for attached workers, so that as with the health visitors, people know each other's names. They have trust based on positive experiences of working together, confidence of what will happen in the future. There are so many relationships of that type that need to be built up between practices in social work and community addiction teams and mental health services and hospitals. And they all take time and effort to build up. That's, I mean, the human resource is the one thing that's actually not in short supply, and we need to be investing in it, investing in relationships of a productive nature. So it's how area-based teams deal with the practices in their area, and it's how the practices in the area deal with their area-based teams. We are doing work just now called the Bridge Project, which is trying to use the practices, knowledge of elderly patients to make better use of the resources available within communities for social and physical activity. And that's all about making a connection with a service, so that there's somebody at the end of the phone whom you know, and there's a previous experience, and you can share it with patients, and they're confident to make the link. This project actually has taken quite a long time, because we're trying to do it without addressing the fundamental problem of resource. So it's being sort of squeezed in at the side. But the general trajectory that needs to be addressed in order to deliver non-fragmented care, it does need to involve the head of social work and the head of healthcare, because cooperation at the top affects everything beneath them. But actually, it also requires relationships at the bottom level of the service. We are fond of quoting a study from Quebec, which was trying to keep patients out of hospital with key workers. And it didn't involve any extra resource, and it didn't involve any extra restructuring. But it did involve the top of the organisation and everybody down being committed to joint working and auditing themselves. And they actually measured it. 0 was that they didn't know who they were. 1 was they knew who they were, but they didn't have contact. 2 was that they had contact. 3 was that they were cooperating, but not closely. And 4 was that they were generally collaborating and reviewing their experience. And over a period of 2 or 3 years, the score went up. And eventually they did actually manage to prevent people, elderly people being admitted to hospital. But of the 4 years that it took to do that, 3 of the years was about building the relationships. And then the system was able to deliver.
Sorry, can I just, at that point, that was, I think, the mindset behind the CHCP. And unfortunately, I don't think they gave it 4 years to build up the relationships that should have been working across the area, because I think that was a great loss in terms of partnership building and making sure that the joint working. So,
can I just come in here and just echo Graham's last point about, I think the key is that it is collaborative working, and there's a subtlety about what true collaborative working is, which is the sharing of experience and then change happening on either side as a result of this. And that is what will make these things work. But there is a process behind that has to go on first about the relationship building. And you've seen already with prescribing, for me in the front line, the key with prescribing is the attached practice-based prescribing advisor. Who's put into practice, we work with them, we know their names, and we truly collaborate. And you've seen, because you're an audit committee, you've seen a figure that is, as a result of that, and Glasgow is doing very well, and that for me is the key. So that same theme is something, for me, why would you not want to build on that? You have evidence that that works.
Would you like to come in?
Sorry, you need to speak into your mic.
Oh, my apologies. Dr. Canson, would you like to talk about partnership working, given you were speaking about it earlier on, and the role that community planning partnerships could play in that?
Thank you. I was struck in your earlier session about the link between anxiolytics and hypnotic prescribing and deprivation. And I think what often gets missed is the role of anxiety, sleeplessness, suffering, unhappiness that is associated with poverty and many things that go with that. It would be incorrect to think that prescribing things like statins is good medicine and prescribing anxiolytics is poor medicine. People die from suicide, and in fact people probably die young from misery, because heart disease and cancer and so on are caused by the lifestyles which themselves derive from unhappiness and difficult circumstances. So drinking, risky lifestyles, smoking, obesity are very often linked to alienation, lack of contact, loneliness, domestic violence, and so on. Now, within general practice, we are trying to address several agendas when we see a patient. On the one hand, we have a list of single-issue guidelines where we're trying to treat someone's illness according to guidelines that are designed for people with one illness only. So if someone has heart disease or high blood pressure, we're trying to address that. On the other hand, the reason the patient is coming to us is very often because of the things that are causing them great pain and stress, whether it's chronic pain, which itself is often linked to unhappiness, or anxiety and the many, many physical symptoms that people have from anxiety. Now, I think that the relationship that we build with them is very important for people, but I don't think that we can do that on our own. I became a GP because I believed that I could work and live a long time with a community, build up relationships, be part of community planning, be part of long-term planning, and actually help not only to change the individuals, but change the communities that those individuals live in or play a part in that. That has not been my experience. I've found that the whole of my time is consumed in being reactive, trying to respond to overwhelming demands and needs. And I think that is a poor use of resources, because I think that the primary healthcare team has much more to offer than simply having to react to overwhelming needs. And there are good examples. There was the Links project, which we took part in last year, where we were given some protected time to go and visit Women's Aid, go and visit Law and Money Advice Centre, so that we could get to know them, so that we could try and signpost and use them more effectively to support and help patients. It was, again, a short-term project, and there has been long-term benefits from it, but I very much think that not an awful lot of investment, but the opportunity to give us protected time and the ability to build up relationships, go to planning meetings. I have done these activities along the way, but that's been very much in my own time as a voluntary activity, and that's not then reproducible on the large scale. So yes, I very much believe that should be a core part of the GP role, of the health visitor role, of the whole primary healthcare team, but that's not recognised in either how we're funded or how resources are distributed. And I think it's very much more a role in a deprived area. I did part of my training in a much more affluent area. The GPs lived in that area. Their children went to the same school as their patients. They took part in the Parents Association or what have you, simply as residents. Now, I live just outside the G15 postcode, but I don't live in the most deprived part of my practice, and I don't know anybody in our practice who does, or in the practices roundabout. So we don't contribute as citizens, as residents, and yet, so perhaps there's an additional role that we could play in contributing as professionals working in that area, trying to help to change things. I would love to go to the school and have a competition for school kids to produce posters for us to put up in our waiting room. I mean, there's a whole different way that we could work that I think would be a more effective use of the GP resource. Within the configuration of the amount of manpower and the way the GP contract is done, I don't really see that happening unless there's something significant, unless that gets recognised as being a key part of what we could do. But I think it would be a better use of the time that we give.
Can I just ask very briefly?
Questions and answers a bit shorter.
Yes, okay, just very briefly. Well. I did specifically mention the breastfeeding project. Do you think that the CPP involvement could help with local issues such as that?
I think that what we had previously when we were a CHCP rather than a CHP now, I think that what we had with the Cell 36 girls locally was fantastic for us as staff. We were very well supported, we learned a lot, they were very good at sharing their knowledge, but more importantly it was very important for the families, because, as I was saying earlier, though there were 5 team members there and they would come and sit, we don't have the staffing levels to go in and sit with a mum for an hour, 2 hours, to help her with a baby who is on and off, where there's problems. Breastfeeding is the most natural thing in the world, but it's not actually the easiest thing in the world. And regularly we have to put a lot of, these mums need a lot of resources. And I have to say that we're not giving it because we don't have the time to do it. There's also an issue around about staff training. We've had a load of new staff nurses starting. They're not going to be trained. So perhaps this would be an opportunity for us to have another look at what's actually needed to support families locally, rather than having them traipsing halfway across the city to the Western or to the Southern or to the Royal for a problem breastfeeding clinic. Perhaps we could, well, not perhaps, we definitely need to have something locally, because these families are just not going to do it. And we know the benefits, the health benefits, the long-term benefits of something as simple and as basic as breastfeeding.
Okay, thanks. Mr. Beattie.
Thank you, Mayor. Just 3 questions, and I'll try and keep it brief. There's reports within the Audit Scotland report that there are difficulties in getting good engagement between GPs, health boards and councils. And we've talked about the need for good partnership relationships to make all this work. Maybe you'd like to give a little bit more information around those comments that have been made.
From ground level?
I think I'd just go back to the previous comment here, that it is about collaboration. And what I hear here from a health visiting colleague is a recurring theme of somebody who's frustrated because there's been something that the professional knows works, delivers what we're asking for, and then somehow, through whatever means, it's been removed. And I share her frustration with that, and I'm sure we could all give examples of it from the front line. And that's what I get back to in terms of true collaboration. Each party has to have a vested interest in making things work and moving things forward. Now, the trick is, how do you get that? How do you manage that from a management point of view? I know how I manage that within my practice team. I have management ways of doing that. That's part of my job. What we're talking about here is extending our role, so we bring these resources in so we know each other's name, so we improve the collaboration. There's no reason why it shouldn't work on a bigger scale with a community partnership, but with the proviso that everybody is on board and, I have to say, knows what the word collaboration means.
So would it be correct to say that at this moment there isn't good engagement with health boards and councils?
It's patchy. This is the issue. It's patchy and it's variable. That's the issue. And so what happens in practice is people will navigate their way through the system in order to find individuals and silos that work for them. That's what I do in practice. I find a way through. I'm sure Peter does the same.
So how can this be fixed? I mean, clearly it's a real problem and it's an obstacle. How can it be fixed?
I think it's a cultural problem. It goes back to the beginning of the NHS and the different arrangements for general practice and the rest of the health service. This is much more difficult to address than the issue of resources because it's about the transfer of power and responsibility ultimately. And I think that my personal view is that for good reasons, but for good reasons that have probably gone past their sell-by date, we tend to have concentrations of power and influence at area level, and that needs to be distributed throughout the community. I liked the analogy of Lennox Castle. You know, that used to concentrate resources in a big institution and people were put away in it. Well, that doesn't exist anymore, and all the resources are now distributed throughout communities with an entirely new set of relationships. I think that's quite a good metaphor for how power and responsibility needs to be redistributed and shared, but I don't underestimate the difficulty of the task. We need good models, good examples, precedents, as Hugh McDermott used to say, not tradition, precedents.
Just moving on to the second question. In your evidence, it says that general practitioners at the deep end would welcome an end to short-term health improvement initiatives. Can you give some examples of this where they've not actually delivered, where the initiative's been started and, as it would appear to say here, it's stalled and just withered away?
Have a Heart Paisley? National demonstration project. Where is it now? What effect is it having in Paisley? It will have had left, I think it's probably left a legacy of some IT infrastructure. But essentially, the way I would characterise many projects is that they're about a first encounter with patients for screening or some other kind of purpose. They always have a problem with coverage, so they start calling patients hard to reach, and they always have a problem with continuity because the money runs out. Well, general practice has got coverage and it's got continuity. It doesn't have the means to exploit the coverage and the continuity. So that's why I would prefer to be investing more in the continuum of what happens after. I mean, if you take Keepwell, for example, which has been very successful in processing a huge number of people through a screening process in order to assess their problems, the question is, what now? Well, what they need is continuity of personalised care that doesn't fragment into lots of different directions. The cardiovascular risks that have been ascertained will be some of the patient's agenda, but not the whole of the agenda. But the important thing about practice is that it's unconditional. You know, it doesn't come with a label on it for heart disease. Whatever you turn up with, whatever combinations of conditions you have, general practice will try and address it. Now that's a hugely important resource to have that non-specialist ability, because if you try and provide specialist resources, Spike Milligan in Pacoon talks about a man who invented a machine that did the work of 2 men but took 3 men to work it. You know, well, that's the health service in a nutshell. We've got a machine that does the work of 2 men, takes 3 men to work it. What we want to invent for the future, because we can't afford the alternative, is a machine that does the work of 2 men and requires 1 man to work it. And that's got to be somebody with generalist skills. Just in passing, you know, one of the things that's missing here is the evidence that would inform a lot of the suggestions. That's why our position is so heavily steeped in experience rather than evidence, although it's high quality experience because of the length of commitment. Can I just say what the English School of Primary Care gets £17 million a year from government. The Welsh School of Primary Care gets 2.7 million. The Scottish Government has withdrawn its funding from the Scottish School of Primary Care for this type of research, which means that we're not going to be producing the evidence to inform the policy, and therefore we will continue to depend on experience and rhetoric.
Given the comments you've made, other than to this committee, how have you given feedback to the government on this?
Well, we've had 2 national meetings and 18 reports, which are available as long and short versions. They're always fed into government. We've had a good relationship with the primary care department in the health department, but we've got to the point now of making proposals, putting flesh on the bones, and the package would include an element of extra time, a focus on the serial encounter, investment in the practice as a hub with attached workers and linked workers to community assets, connections between practices, which is what the deep end has done. It's brought them together for common cause. It's slightly difficult because it's across boundaries from the management point of view, but that's been hugely empowering of practices to share experience and to move forward. There needs to be more support of the frontline practices. Most of the national organisations like NES and CSO and Health Improvement have very low profiles in the deep end. You know, I think that they're ships that pass in the night as far as most deep end practices are concerned. And there needs to be investment in leadership at the local level in order to develop this collaborative relationship with leadership at an area level. And not one of those things on its own will be sufficient. And that's a journey. It's not an instant solution. It's an agreement to go down a different direction in partnership with all the various player. So we're just at the point of submitting that to government. They funded us, the steering group, for an away day just before Christmas, which was the first of 25 meetings that we'd ever held during the day. All the other meetings are held at night time after people have done a day's work. We have got to the curious point that the deep end is well known in England. In Wales, there's an inverse care law initiative that we inform. There's a deep end Ireland. A colleague was in Norway last week, knew all about the deep end. And the irony is that all we've done so far is done the Scottish thing of producing reports. And the real challenge is to convert these reports into action.
In the interest of time, I'll leave it at that. I was going to just comment on the previous panel. Some information came out that in more deprived populations, the prescription for drugs was 46% more per head of population at a cost of 37% higher. Now, the spend was 37% higher. And I was wondering how practices coped with that.
Can I speak from the front line here? I think, again, this is a very good demonstration of the need that's within the deprived area. At the end of the day, our tool is our prescription. So when you've got these huge differences, it's a nonsense to me that it's not reflected in resource within the primary care health team. And what happens in practice, as I would echo what Peter says, it's not about saying whether giving an anxiolytic is a good or a bad thing to do, but it's telling you that the incidence of these mental health problems are comparatively huge in deprived areas. But there's not a comparative resource in that area that's directly attached to a practice, which is what we're talking about, attached mental health workers, somebody we collaborate with, we know on first terms, and who has a vested interest, so that as an alternative to the prescribing of an anxiolytic, we have another resource. At the end of the day, within the confines of a 10-minute consultation, there really is only a certain limit to what we can do. Either we prescribe, or as Peter says, we invest ourselves. And if you've got serial encounters with many, many people with these same problems, there does become a limit to how often that can be done. So it is the attachment of the resource, and it's the collaboration at a higher level of people who are willing to listen to that and are willing to understand that and back up with movement of resource. And there's been a devaluing of the primary care mental health team historically since I've been in practice. You hear it in our health visitors' comments here, where at one point it certainly seemed to us that the primary care mental health team was going to disappear, and that devalued us, it demoralised us, and there was the leadership element was undermined. So there needs to be a restoration of that position so that we can achieve an equality in this collaboration. So that is maybe one of the things that we need to work on to solve the problem.
Okay, thanks very much. Doris, another plea for succinctness.
I hopefully have a number of very brief questions, Convener, but I think firstly, Professor, yes, indeed, we'll have to audit that. Professor Watt, you'd mentioned the last 20 years with an issue with health inequalities. Sir Harry Burns to the Health Committee said it was the last 40 years health inequalities have emerged, and it's due to significant economic inequality within society. So just to put on the record, you can't tackle that at a local level, but there's things you can tackle, and that's what we're looking at today. And indeed the Health Committee has just launched a significant health inequalities inquiry, which will run through the next few months, so hopefully there will be some good input into that. But I do want to look specifically at the Audit Scotland report we have here, and one of the items within it is that people in deprived areas are twice as likely to miss hospital appointments from those in the least deprived areas. I think it's up to 12% of people in deprived areas. So that's a huge cost in terms of cash to the health service, but obviously in terms of their need and care being addressed, that's also a significant cost. So given the time, some brief comments on how we address that and whether or not that pattern is repeated at a GP surgery level for missed appointments would be quite helpful to the committee, I think.
And as a GP, that's very recognisable, that our patients, a high proportion, don't go to hospital appointments. It leaves us managing quite complex health conditions as generalists, where we'd be more comfortable having specialist support. It leaves us and health visitors spending a huge amount of time chasing children for orthoptics appointments, for example. Now that screening is done at nursery, children are getting screened and then not going to orthoptics. And it's a huge extra workload for health visitors to try and get children to go to developmental assessments and so on, sometimes leading to child protection procedures because children are missing appointments. And it's a huge cost to patients' health. If I have a patient with epilepsy who repeatedly doesn't go to epilepsy and he's having seizures, then that's a huge cost both to health and to risk of dying. So it's very recognisable, and it's just part of the extra burden that the primary healthcare team is trying to carry, where someone from a more affluent area is actually having access to services that they're not having access to otherwise.
Okay, can I ask whether or not there's a follow-up on that? So someone misses a hospital appointment or a GP surgery appointment, yes, you can send them a letter. Are we allowed to pass this on to a supportive third party who can chat their door and say, you know, we noticed you didn't turn up for a healthcare appointment. Is there anything we can assist you with? And the balance between confidentiality and actually directly helping vulnerable people access the healthcare they need. Are there any initiatives around encouraging people to attend appointments?
I think the reason why deep end GPs are so keen on attached workers, you know, for mental health and alcohol and addictions, is because then the referral is local, immediate and familiar, and that is more important in deprived areas than in affluent areas. To make a journey to a strange place is less likely to happen. Maybe in the future it would be different, but that's the argument for attached workers based in the practice, is that the referral is more likely to take place if it's local, timely and to a familiar person and place.
Someone tapping the door won't make any difference, to be honest with you. It would simply be paying someone to go around and tap the door. The fact is they've waited quite a long time for the appointment. There's a routine reply as I didn't get it through the post. I don't know whether they do or they don't. I don't know whether they're sent out in the first place. I don't think employing someone to tap doors that they don't know is going to make any difference. A GP phoning up and saying, why didn't you go? Don't you realise how important this is? I'm really disappointed you didn't go. It really matters to me that you should go. Will you please make a big effort to go? That might make a difference. But I don't think a stranger saying, I'm the liaison outpatient appointments person coming to you because you didn't go to your appointment, I don't see how that would make any difference, and they probably wouldn't even get in the door.
I think the key thing is, sorry, apologies,
yeah. Can I just come in here and echo what Peter's saying? I don't think it does work. And what it reminds me of is the work that I saw that Stuart Mercer has presented about enablement and empowerment, and that you don't, enablement and empathy, and that you don't get enablement without empathy. And what the key is about the DNA is, and the research has backed this up, is that patients do things if they feel that somebody cares. So in order to feel genuinely that somebody is sincere about the fact that they're caring, they've got to know and trust that person, and that's been through a whole history of serial encounters. And I've certainly had that. I can remember a patient who didn't turn up for a breast appointment, and I in fact did go to her house, and a whole series of events came out as a result of that, and she still lived from her breast cancer. So yeah, the anonymous person. But to answer your question briefly, has any initiative shown that? I don't think they have, no.
We do. We would, if we were informed that a child had not attended particular appointments, we can't do it for everyone, so we almost have to make a decision about who needs it most. But we would follow that up with a phone call or a visit and just discuss with the parents why it was important that the child attended this, and if necessary, it's not unheard of for us to accompany them to the hospital. We have a support worker. All the teams have at least one support worker, and usually we would ask a support worker to go with them, having ascertained exactly why. Now sometimes for, again thinking about our particular population, it's because they don't know how to get there. They can't read the bus destination boards. They are not confident to use the underground, so to get from Govan Hill to York Hill is a fair journey. and particularly if you don't speak the language and you certainly don't read it. Sometimes it's financial, and that's not just for that one population, but within the community, every pound's a prisoner, and sometimes it really is just about getting themselves there, the cost of getting themselves there, and obviously there's not anything that we can do about that. But for the children, and if there's 2 DNAs, it does become a child protection following an incident a few years ago with a child not having their plaster cast removed.
Yeah, I think I know there are lots of initiatives like that, and these initiatives, in fact, have grown up out of a recognition for the need because of the vulnerability of children, and we've just initiated them off our own bat, but there's no official evaluation.
It's only a comment, Convener, not another question. I've scrubbed out 2 questions after your appeal, but I think the comment would be that the quite powerful message I'm getting is the follow-up for missed appointments is essential, but it can't be a cold-calling anonymous person. It has to be someone who's embedded within the community that they already have a relationship with, and so we don't get drift towards the Health Committee and keep it to public audit, given the fact that 12% of hospital appointments are missed in the most deprived communities, and that's recurring with GPs appointments. It wouldn't just improve the care of the patient, it would actually potentially save the health service money as well, and I think that was quite a powerful message you gave. Thank you.
One of our proposals is for a link worker, a lay link worker in the practice who can oil all of these wheels. You know.
Could I just correct? I don't think Mr. GP appointments is in the same category because we're open access. So someone who's missed a GP appointment can simply make another one. If you miss a hospital appointment, then you're struck off and you're back to square one, and so you won't see anybody. So there is a distinct difference between not turning up for a GP appointment, which is much less, and not turning up for a hospital one.
Okay, thank you.
Thanks very much, Mr. Coffey.
Thanks very much, Convener. I've only one question, and I would invite a response from the panel if they so wish. Can I just say how really impressed I've been with what I've been hearing this morning? Some of it's quite moving, actually, Convener, to hear the commitment and dedication and so on from our colleagues. One of the statistics that Professor Watt gave us in your opening remarks was really quite stark, in that the healthy life expectancy, he said, in deprived communities for men was 57 years, but in most more affluent communities was 76. And it was just as bad really for females as well, those statistics. Do you feel in the round that the kind of interventions that we've been talking about today, like Deep End and Keep Well and so on, are these the kinds of measures that will begin to turn that round? And I know it could perhaps be a whole generation, even a lifetime, till we see that gap closing. Do you feel as though the kind of work that we're doing in the health service is beginning to make inroads into that? And if it's not, what else should we do on top of that to try and assist?
It's a bit like Eric Morecambe playing Grieg's piano concerto. We've got all the right notes, but we don't play them in the right order. I think the intervention that is that's key is an unconditional continuity of care for whatever problems or combination of problems people present. That's the starting point, and then you play other things in, and that puts the patient at the centre. It doesn't put the professional doing a particular thing at the centre at a timing of their choosing. I think that's what we have to build. We have to build the centre is the patient experience. A practice needs to build a compendium of stories around patients in which they are becoming more knowledgeable, more confident, and better at using services and living with their conditions. And the initial gains will be in terms of morale, coherence, quality of life, empathy, enablement. And as people become more knowledgeable and confident, they will stay out of hospital. You know, the things will happen to them less chaotically. That's the aspiration. And I can't give you evidence to show you that that works. But the opposite is quite a reasonable argument, that surely impersonal, fragmented, partial, discontinuous care delivered by people who are stressed and who aren't thinking about the future is a recipe for premature use of emergency services. So the question is not whether, but how.
Okay. Could I perhaps hear a comment from on those.
Yeah, I'll come to this. I mean, as I say, I've been involved in Keep Well. Part of the answer to your question is yes, we are starting to do the right thing. There is a concept within Keep Well that is good, and it's reflected in what we've talked about today. And it's about doing more. If you ask me personally, are there areas that we're maybe neglecting? I would be saying we maybe didn't start Keep Well at an early enough age. We chose, originally it was 45, and now it's 40. For me, if you'd asked me, I would have started it with people in their 20s. That's a personal observational thing. I would also put in more input into the early years in a more practice-based, intensive way. Who are we missing out? Mary Scanlon's question. We're missing out patients who can't be categorised as difficult enough to get into a service, but we know have got issues. And the sad fact is that with a little bit of extra support, these people can be turned around. And these people are people who are part of a community, and changes within them will impact on other people they're connected with. And there's research that's been done that I've read about in America that shows you that. So the short answer is yes, and the long answer is kind of no. I'll try and be brief.
Can I just talk about a patient that illustrates how, very briefly, her dog died, okay, and came very distressed, and for some people that's very, very deeply distressing. Turned out that she'd actually been having severe angina for 3 months, and severe lack of circulation in her legs, and she was drinking heavily and extensively lonely. We've managed to get her to go to specialist appointments, and been able to help her to stop drinking. And very gradually she's working towards the idea of starting medication for her conditions. But part of that is looking at perhaps fostering an animal or finding some way of addressing her loneliness. And we've talked about loneliness with her as being a major cause of ill health and trying to help her address that. Now, that's a long-term project, and that's not an initiative. That's for me, that's a long-term commitment to her, to saying how can we improve your healthy life expectancy through addressing the key factors in your life, bit by bit, not hitting her with all the 20 things that need to change, but bit by bit changing those things. I think if that's reproduced at a mass level, that has to make a difference. The question is, do I have the time and resource to do that with lots of people, or do I just select out those individuals where I think it's going to make a difference? And I think that if we do that with lots of people, then you have to make a difference to healthy life expectancy.
Thanks very much. Don't know, Ms. Eggleston, do you want to? No? If you had anything to...
Well, I would really just echo what my colleagues are saying. I think we're on the right lines, but we've a long way to go.
Okay.
Brief.
Well, thank you very much. I really appreciate that. That was a long session, but it's an area that the committee have pursued over a number of reports, and so it seemed right to give us the time to explore where we were going. So, thank you. You can if it really is one thing, yeah. Professor.
What can GPs do to address inequalities of health? By increasing the volume, the quality and the range of what they provide for their patients.
Okay. Thank you very much. And we'll now break just for 2 minutes to change witnesses. Sorry, when the wit. Okay, we'll reconvene, and here she is. Welcome our last panel of the day, and welcome then Dr. Castaker, who's Director of Public Health for NHS Greater Glasgow and Clyde, and Dr. Schooler, who is a consultant in public health. And the purpose of this session is to look at how funding is targeted by a health board on tackling health inequalities, and how they monitor that as well, how they monitor performance. So I'm going to ask Dr. Castaker to make a few opening remarks.
Thanks very much, and thanks for the opportunity to come and speak to you. As doctors in public health who work at a health board level, we, like others, very much welcome this report that highlights, again, the issue of health inequalities, particularly coming from Greater Glasgow and Clyde, which contributes hugely to these inequalities that this report highlights. But like others, I would like to say that although this report focuses on healthcare services, and that's what we're here particularly to talk about, obviously if we're truly going to tackle health inequalities, as you've heard from others, we need that much broader approach. We need to look at a more equitable distribution of wealth, resources and power across society. We need more state regulation of unhealthy environments. We need to promote good work, meaningful activity, and have that very strong partnership with local authorities and other partners through community planning partnerships. Like Harry Burns, who's given you evidence, I would absolutely support the importance of early years interventions in tackling health inequalities, and I'd be more than happy to say more about what we're doing in Glasgow to try and address that. But to get back to the report that we're specifically here to talk about, I do agree with what Graham Watt said in the previous session about the importance of the NHS, both in having a key role in addressing health inequalities, but also in not widening these health inequalities. And I wanted just to make 4 points on the report. The first one is about overall resource allocation. And the report points out that the resource allocation formula, the NRAC formula that you've already talked about, does attempt to take account of deprivation in that formula. Coming from an area such as Greater Glasgow and Clyde, with its very high levels of deprivation, I don't believe it adequately does take account of that. And I think there's two reasons. I think because of the way the formula takes account of supply factors, but also the point that Graham Watt was raising, the inadequacy of our community data means that is not properly reflected in that assessment of need, and therefore the morbidity and life circumstances measure. For example, we spend a large amount on our drug services, more per head of population than other areas, and we still have unmet need in that area. I'm currently working with I'm a member of TAGRA, so we're looking at the MLC component of NRAC and trying to make it more sensitive in terms of deprivation. The figure in, I think it's figure 8, looks at resource allocation across the boards, but actually it looks at it by individual CHPs as a way of saying, look, at a national level, it's distributed equitably. And if you look at that, you'll see in that figure the second highest level of resource allocation, second only to the Western Isles, is East Glasgow. And the least allocation per head of weighted allocation is in East Renfrewshire. Now, both these CHPs are in Greater Glasgow and Clyde. So that is determined locally. We have our own resource allocation model where we give more resource per population, head of population to our most deprived areas, which does mean that we're giving less to our more affluent areas. And the other issue I would say that makes that we have to think about in terms of how a resource is allocated at a local level is the overriding focus that we have as national policy on access targets. Now, it's absolutely appropriate that we should have waiting time targets, etc., but that does mean we have to use so much of a resource to meet that, and also the overriding concern to retain the current configuration of acute services, again, means it's difficult for us to divert resources into early years or into addressing health inequalities. The second point I'd like to make in the report is about access, and you've already had quite a lot of discussion about DNA rates, and I think that's absolutely appropriate given the strong social patterning we see in DNA rates. And it's not just as simple as transport or locally delivered services. In paediatrics, for example, we have local paediatric clinics. Our DNA rates are just as high there as they are in the if people are expected to come to York Hill. But we are doing a lot of work with that, particularly with our managed clinical networks. So, for example, with the diabetes managed clinical network, looking at specific groups with specific needs, ethnic groups or groups in deprived areas, about how services can be configured in terms of our clinical services review in order to try and reduce DNA rates. And we're also looking at cannot attend rates. It's absolutely appropriate that people are offered a quick appointment, sometimes at short notice, wherever the quickest appointment can be. But for some of our most deprived groups, if they live more chaotic lives, that might be more difficult for them to attend, and they might be then classed cannot attend. So we are undertaking, and I've just finished an equality impact assessment of our own access policy to try and look at these potential risks and plan ways to address that. In terms of some of our screening programmes, as you know, most affluent people are more likely to take them up. And again, there is a risk that we widen health inequalities. If we look at bowel cancer, one of our new screening programmes, there is no difference, major difference by social group in terms of the incidence of bowel cancer, but there is in the uptake of bowel cancer screening. So there's a risk that we widen that inequality. And the way you're called for bowel cancer screening is you're called on your birthday. So you're not called in we don't have a community that we're saying, right, Postle Park's going to be the focus of bowel cancer screening this month. Therefore, we'll put energy into trying to get the uptake rate, or it's not done in households. So we need to, when we put in place new screening programmes, be thinking all the time about inequalities and how do we plan them in a way that won't widen inequalities. The third point was about the inverse care law for primary care, which you have talked a lot about. And we support what the deep end practices would say about the increased complexity and need in the most deprived areas. But as Graham Watt himself said, it is much wider than just GPs. It's about health visitors that you heard about. It's about other members of the primary care team. And we certainly allocate health visiting services higher levels in our more deprived areas. And we're looking, and I can say more about that in the questions, about how we're looking at our health visiting services on a skill mix basis to make sure our most vulnerable families are getting the most intensive support. But it's also about links to benefit services and other agency services. In terms of how we allocate resources to primary care, it's mainly through a nationally negotiated GP contract, which we have limited influence on. But there are certain parts of that contract, the 17C aspect, which gives us a more flexible way of funding GP practices so that we can give additional resource to those in the most deprived areas. And we've currently got work going on in Greater Glasgow and Clyde to see can we make more use of these aspects of the GMS contract. But if there is going to be Scottish negotiation around the contract, then I would very much encourage us to focus on how do we address inequalities and anticipatory care. And lastly, although we both agree that the inverse care law in primary care is important, what's more important is what, again, you heard about in the previous section about the connections and how primary care works and the quality of prevention services. And we've learned a lot from the Keep Well programme, which Anne can say more about in questions, looking at critical control points in getting that quality as good as possible. So it's the access and the engagement, and we found outreach workers do work in Keep Well, people going to folks' door if they're well engaged with the practice. The quality of the consultation is crucial. inequality sensitive practice, the support practices get, and some of the tools like intelligent templates, so electronic tools to make sure that consultation is very patient focused. And then lastly, what you heard a lot from Peter Costin about social prescribing, the referral on to other services, and some simple things like having really good up-to-date electronic directories for primary care, that they know the services, they know how to refer, they know how to describe it to a patient, so that in a 10-minute consultation or they can refer on and know what type of service they're referring on to. So I think that's all I wanted to say, and we're happy to answer questions.
Okay, thanks very much. You made the point there quite clearly that you feel the national distribution to boards doesn't adequately reflect levels of deprivation in different boards, but you did acknowledge that there is an element of the distribution formula that does that, as does the Audit Scotland report. But it then goes on to say, the Audit Scotland report goes on to say, there is no national or local information about how NHS boards allocate these resources, additional resources for deprivation, locally. And further, in the next paragraph, 29, it says, there is no information about specific spending on addressing health inequalities. I mean, how can it possibly be that a health board can't track or tell Audit Scotland or us how they're spending those resources to try and address health inequalities?
We can certainly tell you what we're spending, and I used the example of the east or the northeast sector of our Glasgow CHP. That's one of our most deprived areas. We can show we spend more per head of population in that area than we do, say, in East Renfrewshire or Eastern Bartonshire, which are more affluent areas.
So do you feel that when Audit Scotland say there is no information about specific spending on addressing health inequalities, no national or local information about how NHS boards allocate these resources locally, they're just wrong? If you have that information?
We do have some information, and some of it depends whether you're saying, we don't have information on what we're spending in our deprived areas compared to our affluent areas. Obviously, in the acute side, where the majority of our spend goes, it's very difficult to say, well, this is what I spend on people coming from the East End deprived areas of Glasgow, compared this is what I spend. But we can look at our admission rates by deprivation, we can look at our treatment rates by deprivation, many activity rates by deprivation, and show there's higher rates.
So you feel confident that you are able to demonstrate that the additional funding that you get allocated because of levels of deprivation as a board, although you might wish it was more, but what you do get, that you can track that to how you spend it in order to address health inequalities?
I'm not confident that we can spend the additional, because of the reasons I said about the focus on access targets and the focus on retaining the current configuration of services in the acute side, I don't think we do have an opportunity to actually shift resources specifically into tackling health inequalities in a way that, as a public health doctor, I would like to see.
One of the things in your introduction where you did say that you did that was, you said that you allocated health visitor resources, not predominantly, but disproportionately to areas of deprivation because there was more need. A lot of our discussion and some of the report has been around the distribution of GPs, not just as GPs, but as the centre of that wider primary care team. And there's been a lot of talk of QoF and all the rest of it. Isn't the truth that your life would be a lot more simple and you could do this more effectively if you employed those GPs instead of them being private contractors?
Yes.
Okay. Thank you very much. Mr. Dorn.
Thank you. I'm surprised that the Vice Convener wasn't coming in. You caught me in the hop there.
Fair enough. Excellent.
I'm sure she is. Okay. It carries on from my question to the previous panel about community planning partnerships. How do the health boards ensure that the contribution of the primary care to reducing health inequalities is taken account by the community planning partnership and by the single outcome agreement? as part of the single outcome
I
agreement?
mean, we work hard with our community planning partners to make them work, and certainly in our single outcome agreements, we have agreements with our 6 local authorities around issues that relate to health inequalities, and some of that's about behaviours around smoking or alcohol-related harm, but a lot of it's also around employment and education, etc. I think you're right that GPs per se are not intimately involved in that community planning, but a lot of the work that we're trying to do, which is create our health improvement services much more on a neighbourhood approach, and that's a lot been influenced by that asset-based approach that Harry Burns and others talk about. We need to make sure now health visitors and members of the primary care team are involved, but it'd be good to get GPs much more involved in that neighbourhood approach. And I wonder if Anne wants to come in there and talk about some of the work we're doing in Drumchapel and other areas to try and make that a reality.
Oh, thank you. Yes, I'll be brief. Essentially, we, I think, recognise, building on the very long history that we've had of short-term projects which have sought to address health inequalities, we were very keen in the Keep Well programme that we should learn from these, including Have a Heart Paisley. We haven't had, Have a Heart Paisley didn't wither on the vine. It's actually been woven into what Keep Well is becoming and continuing to develop as. We want to see the Keep Well programme really become much more embedded, and part of what Linda has described is something called community orientated primary care, which I think very directly responds to the concerns that Graham Watt articulated about having primary care teams who understand intimately the needs of their patient populations, and indeed, as Peter outlined in Drumchapel, a very clear understanding of the wider determinants of health. Not all GPs have the passion about public health that Peter has, and it's absolutely laudable that he has. We want to see more of that. And the work that we do really essentially does the joining up of using primary care teams as diagnosticians as what's wrong in the community. We just basically encourage them to bring other services which are in the community, sometimes voluntary organisations, sometimes statutory ones, to come and share mutual learning about where pathways can be better. And actually I've had a lot of surprises from facilitating that work. It's a small scale. One of the challenges I think is how we grow that, but I think it does have some very, very important nuggets for doing things well. We've done a lot of very useful collaborative work with some local organisations, changed some of the pathways for referral management into Glasgow Life and our Glasgow Weight Management Services, actually changed some of the food and nutrition resources that are available because it just wasn't working before. And I think you've got to get that close to services and the interrelationship and really grow public health organisations on that sort of area level that then becomes influential at a community planning partnership level, and more importantly at national level as well. And all of that's got to be a coherent whole. I think, as everybody who's given evidence to this committee has said very strongly, health inequalities have an NHS dimension, but we've got to get the other bits working in synergy, and it's synergy and connections that I think are the two words that summarise that work.
Just further to that then, are you saying that the GPs you're working with just now are feeding into the community planning partnership in the local area?
Yes, it's an indirect link, and I think it could be strengthened. What they're feeding into at the moment is a Keep Well initiative, which is basically, I think Keep Well, as many people have said this morning, it should be much more than a clinical intervention. It should be the beginnings of a relationship between a patient and a healthcare provider, primary care. We've fought very hard to keep Well as a primary care-based initiative, a general practice-based initiative, but that's got to link up very coherently with the health improvement initiatives. And obviously our local CHPs have strengthening links with community planning partnerships, and as we build this sort of approach, I think it does actually begin to address some of the very long-term fragmentation issues that have been a problem of the way we've developed things, and then structures have changed over the years.
One last brief question then. How do you, or what could we do to encourage the GPs who don't take part in this? As you said, that some do and some don't really see the benefit in it. How do we encourage those ones to see the importance of it and to take part?
I think the issue Peter Costin actually highlighted, and I recognise as well, at the moment we're doing this as enthusiastic amateurs. We haven't built in the time that's required for GPs to do that. Peter Costin is doing it because he's a very passionate believer in doing this. I do it as a busy public health doctor alongside my other jobs. If we're serious about doing this, we need to build the structures and the investment and the time required to do it. But I do believe that it actually contains the right ingredients of the drivers of health inequalities. And actually, we talk about health inequalities as if they were one topic area. They're not. There are a myriad of things that drive poor health over the life course. And we can't just say we're investing money on health inequalities as one lump in mass. It's actually got to be about looking at all the work that Sally McIntyre did in the original task force work shows very powerfully that health inequalities are driven by different things at different points. So we need to invest in all of these things seriously.
Maybe I could just say one of the things we've done in Greater Glasgow and Clyde is appoint a GP with a lead for deprivation to lead our deprivation interest group, and that flowed partly from the deep end. So we've given dedicated sessions to a GP to bring together, and it's the broad primary care team, it's not just general practice, to look specifically at mental health or specifically look at child health, set up areas of work and doing that in partnership with other agencies.
Thanks very much.
Yeah. Thanks very much, Ms Scanlon.
Yes, I just had a bit of déjà vu there, because a lot of what you're saying, we've actually heard that for the last 14 years about why isn't there joined up, why isn't there synergy. And, you know, if you look at Exhibit 7, almost everything's relatively stable and nothing's changed. But, I mean, so my brief and only question is, why isn't the approach to health equalities, why is it not joined up? Because we're talking about not being joined up 14 years ago, and why isn't it adequately funded, especially for the early years where the evidence exists?
Your latter question, why isn't it adequately funded for early years, even where the evidence exists, to some extent, I don't think as an NHS board we are able to answer that. We certainly do use the evidence that there is for early years. As you heard earlier, we've got the Family Nurse Partnership, which is funded nationally, and we welcome that because it's got a very strong evidence base. It's a very resource-intensive intervention, and what I want to do as we see the pilots of FNP is to take the key learning from that and be able to put that into mainstream services. You'll know that we've got a very ambitious parenting programme in Glasgow, and that's jointly a programme with the local authority, and it's not a phenomenally expensive programme because it's using existing staff, but there is a resource requirement that's come through community planning. And as I've said, we are currently doing a bit of, we do allocate our health visitors and target them at our most deprived areas, which means our more affluent areas have to accept they don't have as much resource as other areas. But we're also just doing a bit of planning work to say, with the new 30-month assessment that's coming in, with the growing evidence of what works in early years, what do we really need in our children and families team, and what's the additional resource we need to do that? And we're then looking at where would we find that within the board's overall allocation. So we're continually trying to do that. Why is it not more joined up now than it was? I think aspects of it are more joined up. I think it is a shame that the CHCPs did not continue in Glasgow, but in our areas like East Renfrewshire, Western Bartonshire, Inverclyde, where we have integrated CHCPs, they are working well, and we are hearing good stories of how the services are much more integrated through that. And we do look forward to the integration of health and social care, particularly if it includes children's services, and that will bring benefits in that joining up. But I think what Anne said is it needs to get down to really local level, and then we need to build that up. And that is quite time-consuming, resource-intensive work, but we're really trying to tackle it.
Okay, thank you very much, Mr. Beattie.
I was going to ask really just a very simple question. Are you satisfied that practices in the deprived areas are adequately resourced at this time? What indicators do you use to ensure that, and how do you make it happen?
We can't make it happen because it's a nationally negotiated contract. So the way GPs are distributed is because and paid for and funded is through the national contract.
Then how do you monitor it? And if you believe that they are under-resourced, how do you escalate that?
As I said, we try and use aspects of the contract that allows us to fund it differently. We've also got our locally enhanced services where we are able to fund GPs on the basis of, for example, secondary prevention. And we've got very, very good data from our locally enhanced services on what the quality and the outcome of that is. Do you want us to say a wee bit more about that? Would that be helpful?
Well, what I'm trying to understand is, does there come a point where you by monitoring the GPs and so on, realise there's a problem in terms of resourcing? How do you escalate that? And have there been instances that you've done that?
Although we agree with the issue about the level of funding for GPs up to a point, I don't think it's the most important issue in terms of tackling inequalities. But in terms of how we have tried to influence the contract, we do that through our Scottish Government colleagues. So we've been asked our views on some of the discussions around the public health aspects of the new GMS contract, and we've been able to feed into that.
Do you yourselves believe that GP practices in the more deprived areas are adequately resourced? I don't mean just money.
I don't know, do you want to say something about no, I think I would like to see a skewing of resource more to these areas of inequality and to these more deprived areas. And we're trying to do that through that extended primary care team. Particularly for me, the issue is about our child and family teams. So that health visiting team with the skill mix attached to that, I think they're an absolute key part of the primary care team. And we want to be able to see additional resources in these teams in our most deprived areas so they can support adequately our most vulnerable families. And we're planning ways that we will be able to do that. In terms of the actual GPs themselves, yes, I don't think it is appropriate that it should be a completely flat distribution. I think we need to have a contract that allows us to have a much more socially patterned distribution. But given the current resources and the contract that we've got just now, the important thing is making the best use of the resources that we've got in these areas. And happy to say a bit more about that.
I think the key thing is making sure that the support services work coherently. We're doing quite a lot in the bits that Graham Watt mentioned about picking up the pieces afterwards. We're actually doing a lot of quite innovative work in helping, it's mainly practice nurses who do the business of long-term condition management, which, as you know, long-term conditions drive about 80% of our inequalities in health in middle age. And we're doing a lot of work in NHS Greater Glasgow and Clyde to provide systems, electronic systems, first of all, to get the right prescribing, which of course alludes to your earlier agenda item. We're actually providing electronic prescribing support, which is shaped by the advice of our managed clinical networks, which again enables primary care and secondary care to develop systems that cross both primary and secondary care to respond to the needs of people, not just with single diseases, but very recently we've developed electronic decision support systems to help primary care practitioners do the right things for people with combinations of conditions, so multiple morbidity
And it's a very, very important development, really, because of the issues that Graham Watt described about the growing burden of premature multiple morbidity in our most deprived areas. And it's a very, very important development, as well, of course, as in older people who, as we live longer, we get different kinds of inequalities that don't just relate to, we focus a lot on multiple deprivation, but we should remember that age is also a driver of different patterns of inequality. We can't put all our eggs into just one basket, although it's a very important one.
You mentioned in answers to the convener that you'd prefer to see the funding formula tweaked to take into account more of the factors that affect health inequalities. And you mentioned that at the moment it already does, but you feel that that extra money is really taken up by the need to address the effect of the inequalities themselves rather than actually tackle inequalities. Do you think if the funding formula was tweaked, that those additional resources would go into tackling the inequalities, or would it simply be swallowed up into tackling the effects of them?
I think because so much of our resource that's allocated to the Health Board has to go into acute care, that that some of that, as you probably know, we are above parity. We're above where we should be if the formula is accurate. So part of what we are arguing is that actually what we spend is based on need, because these patients are coming into hospital, they are being treated. Therefore, how come the formula says we're spending £60 million more than we should be if the formula is correct? So at the moment, all we're arguing is that what we're currently spending is based on the demands and the needs that come to our services. If there was additional money comes, and a lot of that additional money often comes in ring-fenced ways, for example, for early years work or around certain heat targets or around keep well, etc., we would absolutely target that in our most deprived areas. And I think we've shown from some of the programmes we've got that we have done that.
That sort of leads me on to what was going to be my follow-up as to whether you felt that would be appropriate for that money to be ring-fenced specifically for those methods, but you've already answered that in your...
Yeah, I mean, you need to give, obviously, local areas quite a lot of freedom based on their local arrangements and needs, but when money is ring-fenced around a specific issue that it needs to be spent on, we do spend it on that, and that's what's been the advantage of Keep Well. And now it will be in our mainstream allocation, but the programme is well developed now, and we've got it as efficient as it can be, so it's okay for that now to be in our mainstream allocation.
Okay. Mr. Doris.
Thanks very much, Convener. I would like to pursue the point the Convener started on in relation to the resources you get for areas of deprivation within the NRAC formula. Now, we look at the current model, and I'm looking at Exhibit 8. If I'm doing my arithmetic right, which I may not be, you can tell me if I'm not, but like the areas that I represent, such as North Glasgow and East Glasgow, using the weighting mechanism is probably getting up to a third greater resources than, say, East Renfrewshire. Now, what I'm keen to know is on the ground, when I meet my constituents, what they can expect for that. So, for example, we can talk about preventative spend, but what does it mean on the ground? And more specifically, what, say, my constituents have and how that money is spent, and that's going back to the assets-based approach. We've heard about social prescribing. So, you know, GPs may say, do you fancy doing this at Glasgow Life? Well, the question we should be asking is, what would you like to be doing in your local community? And we'll find the resources to make that happen. So, is any of that going on when we talk about the additional resources that Greater Glasgow and Clyde get for the constituents that I represent?
I mean, a lot of that additional resource will be going into direct, or most of it will be going into direct services, whether that's about allied health professionals, primary care teams, all the services that there are delivered through a CHP for their local community, and it's higher in the most deprived areas. The question about how do we involve local communities and how that money is spent is through our public forums that we have as part of the CHP. And you know, they've taken quite a lot of time to really establish, but they're working well now. So patient groups plus representatives of the local population have a say in the delivery of services through the CHP. The even wider question about, well, actually, if you want us to be more physically active, here's what we'd like to be physically active. We're continually doing that in local areas, about asking local communities about, well, if we want you to stop smoking, where do you want your smoking cessation services, or what would help you in terms of the physical activity services you want? So we do try very hard to get local views on that.
Two very brief follow-ups. Firstly, I have to say, given the fact that I've mentioned 2 areas in North Glasgow, perhaps you could arrange for myself to visit one of these public forums to see how they work in practice. That would be quite helpful. But probably more importantly, because for the committee rather than that, would be that waiting. I accept a lot of that has to get into recognising that there's more demand in acute services, there's more need for allied health professionals, just to mop up the consequences of the health inequalities. But given that we are in a preventative spend agenda and direction of travel for public policy, do you earmark a percentage of that additional spending specifically for preventative measures? Because you'll cite examples of preventative measures, and we can perhaps put a cash sum beside that. So is there a set cash sum that you put beside that, and what percentage of additional weighting is it, and how can we follow that pound?
Yeah, the example I would use is our health improvement team. So we've got health improvement teams whose main focus is around prevention, community development, working with local groups, etc. And they again are allocated, the resource that goes into each health improvement team at a sector level and then at a CHP level in Glasgow has that resource allocation model that brings in a weighting for deprivation. So that's why our team per head of population in Eastern Bartonshire is much smaller than our team in East Glasgow.
Yeah. But is the money for the overall project, you can say, yes, we're spending this on health improvement, and we'll weight that to the areas with greatest deprivation, but the money that's in your health improvement budget, is there a set percentage of the overall additional money you get for deprivation from the Scottish Government? Or do you just pick that number each year depending on what number you decide to pick?
What we get is the overall allocation that's weighted by deprivation. And so that doesn't differentiate for health improvement or acute services or whatever. Although there's a slightly different formula used for mental health services, for maternity, for different aspects. But if we get additional money, say for a healthy weight, it is then allocated via the NRAC formula. So it's weighted again for deprivation. So Glasgow would get a bit more than just by head of population because it's weighted by deprivation. But we don't get a specific allocation for prevention and X% more. It's in the overall allocation we get. Does that answer your question?
It does, but I think what it clarifies is Greater Glasgow and Clyde Health Board don't have a set percentage of the additional resources they get to take account of deprivation to spend on preventative spend. You do spend money on it, but you don't have a set budget or a strategy for slicing so much of that additional resources specifically for health prevention. I think that's what we've established.
Although we don't get the money as, here's your allocation by age and sex, and here's your additional allocation. The formula is crude population is the biggest driver, then it's weighted by 0.9%, say, for remote and rural, because we're not very remote and rural, and then we got 1.1 weighting for deprivation, and that comes as an overall.
The point is you don't then take that 1.1% and ring fence it internally to spend on deprivation, isn't it? So,
I think it'd be a very small amount then we would spend.
Could I just add something here? A bit like the concept of health inequalities being more complicated and differentiated as a set of issues. Prevention, I think, that what we call prevention, it's easy to just think about primary prevention, which is stopping a condition happening. So, for example, all the healthy weight initiatives, smoking, breastfeeding, etc. But we should also remember that prevention has an equally, if not more important role in people who have already developed a problem or condition, such as coronary heart disease, diabetes. Prevention is even more vital there because somebody with diabetes has quite a high risk of developing coronary heart disease and other complications. So what it's very hard to actually separate good clinical care that incorporates all the right preventive interventions for people with an existing condition, in which they're really, if we're doing all the right things, there's a vital prevention role there as well. So it's a very artificial division between prevention and high quality clinical care, and we need to remember that a lot of the prevention work and the valuable prevention impact is actually bound up in good quality clinical care across the primary secondary care interface. So it was just really, I suppose, to widen out the point.
No further questions. Just to say, I appreciate that, but when we're trying to follow the pound as an audit committee, sometimes it's difficult to take that into account when we're asking our questions.
I could come back to you with more information specifically on what does each weighting in the formula equate to in terms of money, and you could. I think you'll find we spend substantially more on, well, certainly substantially more in our deprived areas, but also on prevention than you would see in that weighting. But I'd need to come back to you with the figures.
If you're willing to do that in correspondence, that would be, I think that would be appreciated. Answer Mr. Doris's question. Okay, thank you very much to Dr. Castigar and Dr. Schooler for your evidence this morning, and also your forbearance in waiting so long past the time when we expected to take you. Thank you very much. Okay, the next item on our agenda is item 5, NHS financial performance, and this is some follow-up correspondence. We had sought from the Scottish Government. Does anybody, this has been circulated, does anybody want to comment or ask any questions? Mrs. Scanlon? Yes. Sorry?
They're not on item 4? Yeah. Aye. Sorry, you said item 5.
It says 5 on my brief. My apologies, item 4.
Just clarifying.
Well, it's important because 5's in private, isn't it? And we're still in public session. However, the item is the item, as I said. Then do you want to, Mrs. Scanlon, this was correspondence, which you had asked for, I think.
Yes. Yes, I did ask because I wanted to better understand the £1 billion backlog, given that a percentage of it was for buildings that were no longer required, and also I wanted to know what was low risk and high risk, and I'm very grateful. I think we've got a far better understanding of where we are. I think, Convener, I just wanted to really, if I may, ask another question. Given that 240 million is categorised as high risk, I just raised this in the budget debate last week because we've just been given these papers, and the Finance Secretary, I'm sure he knows more about this, referred to the high-risk backlog maintenance to say that this was in the capital budget. And I wanted to know, given that we're talking about backlog maintenance, I wondered if there is an existing budget or if all maintenance comes out of capital or revenue budget. And I just wanted to understand that, because my understanding from the Auditor General's report was that it was probably out of revenue budget, and she was highlighting the significant backlog, but the Cabinet Secretary says it's the capital budget, and that capital budget is determined by Westminster. So I think, given that so much of it is high risk, urgent priority, catastrophic failure, major disruption, etc., I think I would just like to know whether it is Westminster that decides all of this capital budget for backlog maintenance, or how much of this is decided within the normal allocation to health boards? And that's what I didn't understand.
So are you asking that we write back again and ask whether the backlog maintenance is part of the capital budget or part of the revenue budget?
Yes,
is that
yes.
right?
I would just like clarity on that, because it's not what I understood.
Have you got any objections? Straightforward question. Okay. Mr. Coffey.
Yeah, that's...
I just wanted to put on record, I mean, this ticking time bomb £1 billion problem that we were presented with a number of weeks ago, not only at this committee but in the Chamber, now seems to be one of £161 million. That's the figure in Mr. Feely's reply here, that are high risk. That backlog maintenance figure is £161 million, not £1 billion, as we've been led to believe previously. And I'm pleased to see from Mr. Feely's report there that NH boards are well aware of this and are tackling this backlog at the moment. So I think that's a more encouraging response, perhaps, than we were perhaps been led to believe was the case before.
Okay, that's it.
Mr. Dunn. Clarification on the two figures in here then. I mean, we do have a figure of 160 million as high risk, and then at the back we have 240 million that Mary Scanlon mentions.
It's actually 252 million if you if you include the board. So there does seem to be two different figures. Yeah.
That's the clarification.
Well, we could ask for the clarification on that.
That would be helpful.
Again. And I think Mr. Coffey's I was going to say Mr. Coffey's made his point that whichever of those figures
it ain't $1 billion.
He's referring to that it's less than the total, which is $1 billion. So can we agree that we ask for clarification about those two different figures, and also ask whether all of this backlog maintenance in Table 1 is from the capital budget or the revenue budget, or is it a bit of both?
Yeah. That would be helpful.
Okay, agreed. Thank you very much. And we'll now move to private sessions. So if I could ask any press or public to leave.